Hello guys, welcome back to MedicoDays. So today in this video, I'll be discussing about the NEET-PG PYQs of 2025. Quickly moving on to the rapid revision PYQs of NEET-PG 2025 medicine. A patient came with complaint of palpitations and dyspnea for 4 hours. On ECG, he was found to have atrial fibrillation with no other cardiovascular symptoms. Next best step in the management is ventricular rate control. So the patient is hemodynamically stable in this condition. That is, there's no hypertension, chest pain or heart failure symptoms. In stable atrial fibrillation, the initial step is to control the ventricular rate using beta blockers or calcium channel blockers. Cardioversion, electrical or pharmacological, is reserved for patients who are unstable or have an AF less than 48 hours duration after excluding the atrial thrombus. Anticoagulation is indicated based on the CHA2 DS2 VAS score, but it is not the immediate next step here. Next question. A 40-year-old woman presents with dry eyes, dry mouth and dry cough. She requires frequent sips of water while eating. Schirmer's is positive and lab investigation revealed ANA, anti-Rho SSA and anti-LA-SSB antibodies. What are the characteristic features seen in this condition? So here the answer is destruction of the salivary glands and lacrimal glands due to lymphocyte infiltration. So the clinical features are dry eyes, there will be xerophthalmia, dry mouth xerostomia and positive Schirmer's test along with ANA and the antibodies which strongly suggest the Sjogren's syndrome. It's an autoimmune disorder with a strong female predominance. So lacrimal and salivary glands are the primary targets, leading to decreased tear and saliva secretion, Sika syndrome. There is lymphocyte infiltration and fibrosis of these glands, mainly involving activated CD4 helper T cells and B cells, including the plasma cells. So the diagnosis is by the serological tests for the antibodies along with ANA positivity, and labial salivary gland biopsy is the investigation of choice for confirmation. Next question. A 20-year-old patient presents with salt cravings, skin pigmentation, hyponatremia, hyperkalemia and metabolic acidosis. Diagnosis is Addison syndrome. So salt craving, skin hyperpigmentation, hyponatremia, hyperkalemia, metabolic acidosis, all these are features of primary adrenal insufficiency, that is the Addison's disease, and it occurs because of the destruction of the adrenal cortex leading to the deficiency of cortisol and aldosterone. Because of the loss of aldosterone, there is sodium loss and potassium retention, and hypotension and metabolic acidosis will be seen. Because of the low cortisol, the patient will be presenting with weakness, fatigue, hypoglycemia and low stress tolerance. High ACTH, because of the lack of the cortisol feedback, high ACTH will lead to skin and mucosal hyperpigmentation. Next question. A female patient with a known case of bronchial asthma is on levalbuterol and ipratropium bromide meteor dose inhalers. She now reports frequent nocturnal symptoms including wheezing and breathlessness that wake her up several times a week. Most appropriate next step is add LABA and inhale corticosteroids. So patient here has poorly controlled bronchial asthma evidenced by frequent nocturnal symptoms and wheezing several times per week despite being on short-acting beta agonist and anticholinergic therapy. According to the JINA guidelines, that is the Global Initiative for Asthma Guidelines, the next step is to add a combination of LABA and inhalational corticosteroids. So inhalational corticosteroids, they help reduce the airway inflammation, while LABA, it provides long-term bronchodilation, controlling the nocturnal and persistent symptoms. Next, a patient is newly diagnosed with HIV and has had fever for 2 weeks with cough and dyspnea, and chest X-ray shows cavitary lesions in the upper lobe, and patient is to be started on treatment. What is the appropriate strategy? CD4 cells are 150. So here the answer is start ART after 2 weeks of anti-TB therapy. So here the patient has HIV-TB co-infection with a CD4 count of 150 per microliter. So correct strategy is first treat the TB and then start the antiretroviral therapy after 2 weeks. So if you do like this, it will help to prevent the risk of IRIS, that is immune reconstitution inflammatory syndrome. Next, a patient who has undergone knee replacement surgery 7 days back now presents with complaints of sudden shortness of breath and tachycardia. Next appropriate diagnostic test is CT pulmonary angiography, that is CTPA. Here the patient has sudden dyspnea and tachycardia following recent surgery and immobilization, which strongly suggests pulmonary embolism. So the most appropriate and confirmatory diagnostic test for pulmonary embolism is CTPA. It visualizes the intraluminal filling defects and it is considered the gold standard in hemodynamically stable patients. Next question. A patient came with history of dyspnea, fatigue and palpitations for 6 months. He gives a history of acute rheumatic fever in childhood. On examination, JVP is elevated, irregular pulses present, hepatomegaly is there and pedal edema is also there. There was a left parasternal heave as well. So on auscultation, opening snap with MDM, that is mid-diastolic murmur, is present. All are true in this case except. So here the answer is pre-systolic accentuation of the MDM is a hallmark of this condition. That is the false statement. So the clinical presentation here suggests it as rheumatic mitral stenosis, which is complicated by atrial fibrillation and right heart failure. Irregular pulse is seen in atrial fibrillation, which commonly occurs in long-standing mitral stenosis due to left atrial dilation. And JVP elevation absent A wave, hepatomegaly, pedal edema all indicates right-sided heart failure secondary to pulmonary hypertension. Opening snap followed by an MDM at the apex, best heard in the left lateral decubitus position, is classic for mitral stenosis. Pre-systolic accentuation of the murmur occurs due to the atrial contraction, but it disappears once the AF develops. Hence, in this patient with AF, pre-systolic accentuation is not present. Next question. A patient presents with morning stiffness and tests positive for anti-CCP antibody. Which of the following histological feature is most characteristic? Answer is Panus formation with synovial hypertrophy. So here the picture of morning stiffness and anti-CCP antibody positivity is diagnostic of rheumatoid arthritis. This is a chronic autoimmune inflammatory arthritis primarily involving the synovial joints. Hallmark is Panus formation resulting from synovial hypertrophy and proliferation. Next question. A 30-year-old female notices weakness in her right hand and difficulty while kneading dough. On examination, right arm tone and power are decreased and reflexes are sluggish. Slight of lesion is anterior horn cell of the cervical spinal cord. So here the patient presents with focal weakness, decreased tone, reduced power and sluggish reflexes confined to the right arm. So these findings, it is classical of LMN lesion. Anterior horn cell is the site of LMN in the spinal cord. Hence, it's the most likely site of lesion. Weakness which is limited to one limb is the local lesion rather than a diffuse one. It's not a UMN lesion or cortical one. Hypertonia plus diminished reflexes, there is it points to LMN involvement. Anterior horn cells in the cervical spinal cord innervates the upper limb, and common causes include the motor neuron disease, example the ALS, spinal muscular atrophy, poliomyelitis or focal anterior horn pathology. Next question. A 55-year-old patient presents with shortness of breath. ABG analysis reveals the following: pH 7.22, PaCO2 66, PaO2 45 and bicarb is 26. Most likely acid-base disorder is respiratory acidosis. So acid-base disorder is a very, very important question. Every year there will be 1 or 2 questions regarding that. So acid-base questions to solve and to find is very, very important, guys. Next, a patient presents with chest discomfort and palpitations. ECG shows PSVT, that is paroxysmal supraventricular tachycardia. Drug used in the prophylaxis of this condition is oral verapamil. So it is a re-entrant tachyarrhythmia that originates above the ventricles, commonly because of the AV nodal re-entrant tachycardia or accessory pathway mediated re-entry. Drug used for prophylaxis is oral verapamil. It is a class 4 antiarrhythmic agent. Next question. A 19-year-old female patient who is a known case of type 1 diabetes mellitus presents to casualty with diffuse weakness. She had stopped insulin one day before presenting as per mother. On examination, BP is 80/60, plasma glucose is 720, sodium is 126, potassium is 4.3. Which of the following is not a step in the management of this condition? Answer is normal saline 3%. So clinical picture, it is type 1 diabetes plus hyperglycemia, hypotension and electrolyte disturbances. All these points towards diabetic ketoacidosis. Diabetic ketoacidosis is again a very favorite question in NEET-PG. In other exams also it's a favorite topic. So 1 or 2 questions every year will be there in diabetic ketosis also in any of the exams. So please focus on diabetic ketoacidosis and its management. So it results from insulin deficiency and increased counter-regulatory hormones, glucagon, cortisol, epinephrine and growth hormone, leading to ketone body formation, metabolic acidosis and dehydration. Management involves fluid resuscitation, insulin therapy, electrolyte correction and monitoring, but hypertonic saline NS 3% is not used. Next, a 40-year-old male patient presented with complaints of drowsiness and was admitted for evaluation. Sodium was found to be 98, which was corrected to 110 with 3% saline in 24 hours. The patient recovered for a while and had altered sensorium later. Now he developed quadriparesis and bilateral conjugate ease palsy. Investigation to be done in this case is MRI brain. Here the patient had severe hyponatremia that was rapidly corrected using hypertonic saline. This rapid correction of chronic hyponatremia can cause osmotic demyelination syndrome, ODS, also known as central pontine myelinolysis. Classic presentation includes initial improvement after correction of sodium followed by delayed neuronal deterioration. Symptoms are quadriparesis, pseudobulbar palsy, dysarthria, dysphagia, and bilateral gaze palsy. Next question. A patient with HIV with a CD4 count of 250 cells per mm is newly diagnosed to have rifampicin-resistant TB. Which of the following is the appropriate regimen and what should be monitored? So here the answer is bedaquiline, pritomanid, linezolid, moxifloxacin for 6 months, and immune reconstitution syndrome. The patient here is HIV positive with rifampicin-resistant tuberculosis, which is a form of multi-drug resistant TB. Again, TB is a favorite area of in any of the exams. So again, TB related questions will be there, guys. So please learn about the regimens of TB management. Very, very important. And a recommended TB regimen for MDR TB, especially in HIV co-infection, is the BPAM regimen consisting of bedaquiline, pritomanid, and linezolid and moxifloxacin. Duration is for 6 months. Next question. A patient with type 2 diabetes mellitus complains of numbness and burning sensation in extremities. On examination, he has absent ankle reflexes and has no sensation to touch, vibration, or pain in his lower limbs. The loss of sensation in his extremities has a stocking distribution. What type of neuropathy is it? Answer: symmetrical distal polyneuropathy. Here the patient has numbness, burning sensation, absent knee, ankle reflexes, stocking distribution. All these are features of distal symmetrical polyneuropathy, the most common form of diabetic neuropathy. It results from chronic hyperglycemia leading to axonal degeneration and segmental demyelination of the peripheral nerves. Next question. A patient presented with skin tightening and arthralgia. Raynaud's phenomenon is positive. Lab investigations showed ANA positive and anti-SCL70 antibody. Presence of which of the following condition is associated with this? Answer is interstitial lung disease. ANA positivity, anti-SCL70 antibody, and skin tightening with Raynaud's phenomenon are all suggestive of systemic sclerosis, also known as scleroderma. Anti-SCL70 antibody is highly specific for diffuse cutaneous systemic sclerosis. This autoantibody is strongly associated with interstitial lung disease and diffuse skin involvement. Next question. A 68-year-old male with type 2 diabetes mellitus and HbA1c of 8.2% is being evaluated. He has chronic heart failure with an ejection fraction of 35%, currently taking metformin and glargine insulin. Which of the following medication is most appropriate to add for glycemic control in this patient? Answer is empagliflozin. Again, oral hypoglycemic agents are an important topic. Questions related to that will be there in most of the exams. So guys, please focus on that area. Here the patient with type 2 diabetes mellitus with poor glycemic control and heart failure with reduced ejection fraction, empagliflozin, which is a SGLT2 inhibitor, is very important, and that is used. Next, patient presented with right-sided weakness, aphasia, and irregular pulse for last 2 hours. On CT brain, no hemorrhage. What should be the next best step? Answer is RTPA. So the patient with acute onset right-sided weakness and aphasia is suggestive of ischemic stroke. Presence of irregular pulse suggests atrial fibrillation as the probable cause. A cardioembolic stroke. CT brain shows no hemorrhage, confirming that it is a non-hemorrhagic stroke. So the treatment of choice for acute ischemic stroke within the window period is IV thrombolysis using recombinant tissue plasminogen activator, that is RTPA, alteplase. RTPA should be administered as soon as possible, ideally within 3 hours of symptom onset as per the standard protocol. Up to 4.5 hours in selected patients as per the window guidelines it can be administered. Next, an elderly patient presents with increased frequency of breathing and weakness. ABG is given. What is the likely diagnosis? So again, ABG calculation is very, very important here. So guys, in this question which was provided, the answer was acute metabolic acidosis with anion gap of 30 milliequivalents per liter. So primary disorder was metabolic acidosis. Next question. A 35-year-old female with hyperpigmentation, hypotension, and hyponatremia is diagnosed with Addison's disease. Which hormone is responsible for her hyperpigmentation? ACTH. So this again, in 2 forms, this question had come in the same exam paper itself. There was a previous question similarly like to this. So Addison's is caused by destruction of or dysfunction of the adrenal cortex. So again, these hormones, these areas are very, very important, guys. It is leading to deficiency of cortisol, and aldosterone. Because of the low cortisol, there is loss of negative feedback and to the hypothalamic pituitary adrenal axis. This leads to increased secretion of ACTH from the POMC precursor. Excess ACTH and MSH, it stimulates the melanocytes, causing hyperpigmentation. Next, a 65-year-old male presented with fever, cough, and chest pain. Identify the lesion. Answer right upper lobe consolidation. So, chest X-ray shows a homogeneous opacity in the right upper lung zone. Opacity is non-homogeneous with air bronchograms visible, suggesting alveolar filling. Next, a 25-year-old male patient is diagnosed with recurrent migraine despite sumatriptan, has 3 to 5 episodes per week, and presents with features of anxiety and palpitations. There is no clinical neck swelling, no history of coronary artery disease. However, there is a family history of coronary heart disease. She reports experiencing chest tightness after taking the medication. Most appropriate agent to add for migraine prophylaxis is propranolol. So, patient experiencing frequent migraine attacks despite abortive therapy of sumatriptan is here. And she also reports chest tightness after sumatriptan, which is a triptan-induced coronary vasospasm side effect. So, the treatment for that prophylactic therapy is by propranolol, which is a non-selective beta blocker. Next, which of the following crystalloid infusions, when given in large quantities, is likely to cause hyperchloremic metabolic acidosis? Answer is NS. So, 0.9% NS is an isotonic crystalloid commonly used for fluid resuscitation. Although it is isotonic with plasma, it is not physiologically normal because its chloride concentration is much higher than the plasma chloride level. When infused in large quantities, this excites chloride. It causes a reduction in the plasma bicarbonate concentration, leading to hyperchloremic metabolic acidosis. Next question: a 14-year-old developed rapid growth and had long legs and large hands and coarse facial features. Which of the following tests are used to make a confirmatory diagnosis? Answer: no suppression of the growth hormone after glucose administration. So, clinical features of rapid growth: long limbs, large hands, coarse facial features, all this points towards gigantism. So, confirmatory test for growth hormone excess is oral OGTT, that is oral glucose tolerance test with growth hormone measurement. Normal individuals, the glucose suppression, growth hormone secretion. Glucose suppresses the growth hormone secretion, but in growth hormone secreting pituitary adenomas, the suppression does not occur. Next question: a patient presents with bleeding due to the factor 9 deficiency. In which of the following conditions will you find an improvement after administering vitamin K parenterally? So, answer is bile duct obstruction. Vitamin K is essential for gamma carboxylation of certain clotting factors, and these are 2, 7, 9 and 10, as well as protein C and S. So, vitamin K, it is a fat soluble vitamin and its absorption requires bile salts. Surgery, NEET-PG 2025 PYQ. And now quickly moving on to the questions. A patient underwent surgery for duodenal ulcer. During the procedures, the surgeon accidentally injured a structure posterior to the epiploic foramen, and the patient started bleeding copiously into the peritoneal cavity. Most likely structure injured is the inferior vena cava. So, epiploic foramen and its boundary is very, very important. Please take up the image and learn, guys. So, epiploic foramen, it's a short vertical slit situated immediately posterior to the free margin of the lesser omentum and connects the greater sac with the lesser sac. The structures which are posterior to the epiploic foramen include the inferior vena cava, making it vulnerable during posterior injury and explaining copious intraperitoneal bleeding. Next question: a patient presented with following findings in the left lower limb. Identify the true statement regarding the condition. So again here this question is based on the CAP classification. Again, very, very important classification. Please go through it. Now here in this case the answer will develop eczema or pigmentation. So according to CAP classification, visible varicose vein corresponds to C2 stage, which can progress to skin changes if it is left untreated. Ongoing venous hypertension leads to capillary damage causing eczema, hyperpigmentation and lipodermatosclerosis over time. Next question: an elderly male presented with epigastric pain, anorexia, weight loss and jaundice since 2 years, and he had scratch marks all over the body, and on examination gallbladder was palpable, smooth and non-tender. Identify the diagnosis is CA head of pancreas. So here the combination of painless progressive jaundice, weight loss, anorexia, pruritus with scratch marks, all this points towards malignant biliary obstruction. A palpable, smooth, non-tender gallbladder in the presence of jaundice points to the Courvoisier's law, which points that it is points towards a periampullary malignancy, most commonly the carcinoma head of pancreas. Next question: identify the type of node. So the type of nodes and suture materials, again very important area. So here this is a surgeon's node. Please see the images of Granny's node, square reef node. Very, very important. Next, identify the type of suture material. Yes, as said, suture material again very important. So here this is PDS, that is polydioxanone, and the answer here is it is a type of monofilament. So monofilament sutures, they have a smooth surface leading to less tissue drag and better resistance to infection compared to braided materials. And the braided or polyfilament sutures, they usually have higher capillarity leading to increased infection risk. Next question: a malignant neck swelling was surgically removed from a patient as shown in the image. What will the patient likely present 2 to 3 days after the procedure? Answer: carpopedal spasm. So postoperatively, the patients may develop transient hypoparathyroidism because of the ischemia or inadvertent inadvertent removal of the parathyroid glands. So reduced parathyroid hormone leads to hypocalcemia, which typically manifests 2 to 3 days after the surgery. Next question. A 25-year-old male presented to the emergency with a stab injury on the right iliac region. A few hours later, he developed hypotension, abdominal tenderness, and peritonitis. What is the next step? Answer is emergency laparotomy. Again, trauma-related questions, whichever exam it is, be it NESET or NEET or FMG, wherever trauma-related questions are very, very important. Most of the cases, the question might come, what is the investigation of choice in case of unstable patient, or in case of a stable patient, what should be done? What is the next step? So all these very, very important, guys. Next, an 80-year-old child presents with progressive phimosis and a white sclerotic lesion on the penis. Diagnosis is balanitis erotica obliterans. So white sclerotic hard preputial lesion. It is a chronic inflammatory condition of the foreskin. It is considered a pediatric variant of lichen sclerosis and may extend to involve the distal urethra, leading to urinary symptoms. And the child may present with ballooning during micturition, dysuria, and difficulty in retracting the foreskin. Next, the following image depicting bile duct injury shows which type of Strasbourg classification. Again, Strasbourg classification, please go through all the types, the images. So here it is a case of type A. Next, identify what is the diagnosis from the image. Answer is wet gangrene. So swollen edematous hand with discoloration, blistering, and putrefied appearance of the fingers suggests active infection with tissue necrosis. Here the line of demarcation is poor or ill-defined. In case of dry gangrene, the patient will be presenting with shriveled mummified tissue due to slow arterial occlusion without infection. Next question. A 30-year-old female underwent the procedure shown in the image following a brain injury. Which statement is true? Answer: done in circumferential burns. So what the image depicts here is eschorotomy, which is circumferential full thickness, which is done in case of circumferential full thickness burns. It's an emergency procedure, and circumferential burns, they produce a rigid eschar with a tourniquet-like effect, leading to vascular compromise, compartment syndrome, and respiratory restriction when involving the chest. Next question, identify the type of anal fistula. So the images are provided here, guys. Different types, please go through it. Next, a 42-year-old woman had non-specific right upper quadrant pain. The gross section of the excised tumor is shown below. What is the diagnosis? Answer: focal nodular hyperplasia. So it is a benign hyperplastic response of the hepatocytes to an anomalous artery and is commonly seen in young to middle-aged women. Patients are usually asymptomatic, and when present, symptoms are limited to vague right upper quadrant pain. Next, 45-year-old male presented with difficulty in swallowing and weight loss. Barium swallow gives the following finding. And bronchiclity changes are also seen on the chest x-ray. Investigation of choices, manometry. So barium swallow, it shows a bird beak appearance, which is characteristic of achalasia cardia. Again, a very, very common question. This kind of questions, please don't make it wrong, guys. Very, very important. So esophageal manometry is the most sensitive and definitive test, demonstrating raised lower esophageal sphincter pressure and incomplete relaxation. Next question. A patient with hypertensive episodes with an MRI abdomen showing a suprarenal mass is planned for surgery. 24-hour urine metanephrine levels are found to be elevated. Which drug will be given preoperatively and also intraoperatively? Answer is nicardipine. So here the clinical picture is suggestive of pheochromocytoma, which is characterized by the catecholamine excess causing paroxysmal hypertension. So nicardipine, which is a calcium channel blocker, is effective in controlling the BP both before and during the tumor manipulation intraoperatively. Next, a patient presented with rhodinophagia and cervical lymphadenitis. On examination, an ulcerated growth was present on the base of the tongue, which was found to be squamous cell carcinoma. Most likely organism is HPV. So squamous cell carcinoma of oropharynx, especially involving the base of the tongue and tonsil, most commonly is caused by the HPV-16. And HPV-driven tumors often present with small or occult primary lesions and prominent cervical lymphadenopathy, sometimes out of proportion to the primary tumor size. While oncoproteins E6 and E7, they inactivate the p53 NRB, promoting the malignant transformation. Next question. A 25-year-old following an RTA with head injury was brought to the emergency room, and a CT scan showed normal findings, but patient died within 3 hours. Autopsy showed petechial hemorrhages in the corpus callosum, focal lesions in the brainstem, and retraction ball appearance in the internal capsule. What is the cause? Diffuse axonal injury. Again, diffuse axonal injury. Most of the times one question comes in the exam, guys. It is a very common topic, a very important topic as well. Please go through it. Yes, a normal CT scan and rapid neurological deterioration in a patient is usually seen. It mostly points towards diffuse axonal injury whenever it comes in the exams. So next, patient presented with lump on the right breast. Biopsy was done, which confirms breast cancer. Again, staging of breast cancer and the ovarian cancer, all these are very, very important, guys. Endometrial cancer, this is all very, very important. please go through all the cancers and their stagings, like which are important ones which keep repeatedly coming up in the exams. So please go through all that, guys. Orthopedic NEET-PG 2025 PYQs. So guys, if you are interested, you can check out the PDF of this, which is available at a very nominal price of 150, and the introductory offer is also there right now, so you can get it at the price of 50 rupees, and you can also get our 8-year PYQs at a very nominal price. If you want, the discount code is also available, and please check out my Telegram for more info. Now quickly moving on to the questions. A male comes to casualty after an RTA with a mid-shaft fracture of the femur and undergoes surgery. In the ward 2 days later, the patient presents with breathlessness, tachycardia, confusion, and petechial rashes over the chest and conjunctival hemorrhage. The probable diagnosis is fat embolism syndrome. So, pathophysiology: after long bone fracture or orthopedic surgery, fat globules they enter the circulation, and free fatty acids cause toxic vasculitis, and fat globules leads to mechanical obstruction of the pulmonary and systemic microvasculature. So here the onset within 24 to 72 hours, presence of breathlessness, tachycardia, confusion, petechial rash, all these are classical features. Now quickly moving on to the next one. An elderly patient presents with painful right knee with no history of trauma, right knee pain. On synovial fluid analysis, there are rhomboid crystal shaped material seen and positive birefringence on polarized light. What is the cause? So again, this is a very, very important gout related questions, like it's very, very important. So pseudo gout is a condition here. So the rhomboid shaped crystals which are seen are calcium pyrophosphate dihydrate crystals in the joints, triggering an acute inflammatory reaction. And clinical cues, mostly it is seen in case of elderly, and it commonly involves the knee, wrist, and shoulder. In case of osteoarthritis, it's a degenerative disease. And gout, in gout you will see needle shaped crystals, and there will be negative birefringence. It is because of the monosodium urate crystals. So these gout and pseudo gout, to differentiate, very, very important, keeps coming up in multiple exams, very important topic. Next, a 30-year-old man presents to the emergency department following a motorbike accident and is found to have a close fracture of the shaft of tibia. 6 hours later, he developed severe leg pain, which was not relieved by analgesics and worsened on passive dorsiflexion of the foot. On examination, sensations over the first dorsal web space were lost, but dorsalis pedis pulsations were present. Next step in management, answer is emergency fasciotomy. So here, an acute increase in the intracompartmental pressure causing capillary level ischemia, leading to muscle and nerve necrosis if not relieved. So we have to do emergency fasciotomy in that case. Severe pain which is out of proportion and pain on passive stretching, paresthesia with preserved pulses strongly indicates acute compartment syndrome. So presence of distal pulses does not exclude the compartment syndrome because ischemia occurs at microvascular level in this case. Next question. A 20-year-old male athlete while playing football has an eversion injury. Which ligament was most commonly involved? Answer is deltoid ligament. Eversion injury places stress on the medial stabilizing structures of the ankle, leading to injury of the deltoid ligament. That is a medial collateral ligament. So deltoid ligament is strong triangular ligament stabilizing the medial aspect of the ankle and resisting eversion forces. Eversion injuries are commonly associated with deltoid ligament tears or unstable ankle fractures. Next question. A 65-year-old man presents with a bony lesion in the lower limb. He also gives history of an increase in head size. On examination, bone feels warm to touch and bowing of the leg is present. And X-ray showed a mixed lytic sclerotic lesion. ALP level is 250. Normal serum calcium, phosphate, and parathyroid hormone levels are seen. Most likely diagnosis is Paget's disease of the bone. So characterized by increased osteoclastic activity followed by excessive osteoblastic bone formation, leading to high bone turnover. Enlarged and deformed bones will be present. So increase in the head size, warm bones, bowing of long bones, all these are pointing towards involve the Paget's disease. So guys, what will be seen biochemistry level is raised alkaline phosphatase with normal calcium, phosphate, and parathyroid hormone levels. And on radiology, mixed lytic and sclerotic lesions, cotton wool appearance of the skull, and osteoporosis circumscripta, they are characteristic. So next question. A 68-year-old presents with chronic lower back pain. X-ray spine is given. What is the diagnosis? Answer is spondylolisthesis. Yes, this image very, very important. So it is characterized by forward displacement of one vertebra over the other vertebra, which is present below. Most commonly, it involves the L5 over S1. So patient will be presenting with lower back pain, chronic and sometimes associated with sciatica, worsening by standing or walking. Radiological features, X-ray will clearly show the anterior slippage of the upper vertebra, elongation of the spinal arch, and increased lumbar lordosis. Next, a 20-year-old man presents with chronic back pain. The pain is worse in the morning and reduces with physical activity within 5 hours. He has a history of anterior uveitis. X-ray shows a of the sacroiliac joint was normal. On examination, lumbar lordosis was present and spinal flexion was reduced. What is the diagnostic modality for early diagnosis? So answer here is MRI of the sacroiliac joint. So most probably this is pointing towards ankylosing spondylitis, which is a seronegative spondylitis. The features like inflammatory back pain and morning stiffness and loss of lumbar lordosis and also presence of anterior uveitis, all this highly points towards ankylosing spondylitis. And the diagnostic modality for early diagnosis is MRI. Next, an 8-year-old boy has been limping painlessly for 10 months. Given as the X-ray, what is the probable diagnosis? Answer is Perthes disease. So it is because of the avascular necrosis of the proximal femoral epiphysis caused by disruption of the blood supply to the femoral head, leading to osteonecrosis and temporary cessation of bone growth. It most commonly occurs in boys and aged between 4 to 9 years, presenting with painless limping or mild pain of long duration. Hip movement shows limitation of abduction and internal rotation. Radiological features, yes, you can see that there is fragmentation and collapse of the femoral head with alternating areas of sclerosis and lucency. In this video, we'll be discussing about the NEET-PG PYQs of the subject OBG for the year 2025. Now quickly moving on to the details of this video. First question, identify the maneuver shown in the image. So here the answer is Lawson's maneuver. It is used for delivery of extended arms in breech presentation, and it's based on the principle of the curved birth canal, and the shoulder bracement favorable for this position is the anterior shoulder above the symphysis pubis and posterior shoulder below the sacral promontory. And rotating the trunk while keeping the back anterior and applying downward traction brings the posterior shoulder under the pubic symphysis. Baby is grasped using the femoropelvic grip, keeping the thumbs parallel to the vertebral column, and this maneuver is started only when the inferior angle of anterior scapula is visible underneath the pubic arch. The baby is lifted slightly to cause lateral flexion, then the trunk is rotated to 180 degrees and while maintaining the downward traction, then the trunk is rotated in reverse direction to deliver the other shoulder. This maneuver, it is employed in all types of arm displacement, and it does not involve intrauterine manipulation, making it a preferred technique. Next question, the hysterectomy specimen of a 65-year-old patient is given. Most likely diagnosis, answer is endometrial carcinoma. In elderly postmenopausal woman, an irregular friable growth filling the endometrial cavity with myometrial invasion. It strongly suggests endometrial carcinoma. It may be localized or diffuse and can appear as a nodule, polyp or diffuse lesion involving the entire uterine cavity. The risk factors are PCOS, HRT, obesity, hypertension and diabetes. The most common clinical feature is postmenopausal bleeding or discharge. The uterus may appear normal or bulky due to tumor infiltration, fibroid or pyometra. Other options, like in case of adenomyosis, it shows endometrial tissue within the myometrium producing a symmetrically enlarged uterus with diffuse non-capsulated involvement rather than irregular cavity filling mass. In case of endometriosis, it refers to endometrium outside the uterine cavity like in ovary, pouch of Douglas, peritoneum, and it does not involve the endometrial cavity in hysterectomy specimens. Fibroid or leiomyoma, it is a benign smooth muscle tumor presenting as a well-circumscribed firm mass with whorled appearance, not as an friable irregular endometrial growth. Next question, a 32-year-old with gestational diabetes mellitus and fetal macrosomia is in labor. The head is delivered but shoulders are stuck even after 1 minute. Sequence of maneuver, answer is McRobert, Rubin, Gaskin and Zavanelli. So delay in the delivery of the shoulders for more than 1 minute after delivery of the head indicates shoulder dystocia. McRobert's maneuver, it is the first line step involving sharp flexion of the maternal thighs onto the abdomen to straighten the lumbosacral ankle, rotate the pelvis and free the impacted shoulder. Suprapubic pressure, it helps reduce the shoulder diameter. The Rubin's maneuver, it involves rotating the accessible fetal shoulder to reduce the bisacromial diameter and bring it into the oblique plane. Gaskin maneuver, which is the all-four position, it increases the pelvic diameters and facilitates shoulder release when initial maneuvers fail. And Zavanelli maneuver, it is the last resort involving cephalic replacement followed by cesarean delivery. Diagnostic features of shoulder dystocia, it includes the turtleneck sign, then failure of spontaneous restitution of the fetal head, then plethoric fetal phase and failure of shoulder descent. Next question, a primary gravida at 37 weeks presents with decreased fetal movement for 1 day. NST showed 1 acceleration in 20 minutes and no deceleration. Next step is answer, continue NST for 40 minutes. So at 37 weeks, an NST with only 1 acceleration in 20 minutes, it is considered non-reactive, but this is not definitive. So before labeling the NST as abnormal, it should be extended to 40 minutes as fetus may be in the sleep cycle. In NST, 2 or more accelerations of more than 15 beats per minute above baseline and lasting more than 15 seconds within 20 minutes, they indicate a reactivity. Absence of decelerations and presence of at least 1 acceleration suggests that acute fetal distress is unlikely at this point. Immediate induction, it is not indicated because NST abnormality has not been confirmed yet. And emergency LSCS, it is reserved for evidence of acute fetal compromise, which is not present in this case. And instrumental delivery, they apply only when the patient is in second stage of labor, which is not the case here. So guys, you need to have an idea about how to rule out the other options as well, because these other options, they can come as potential questions in the next exam which is coming up. So always go through the options as well. You need to have a little idea about them. Next question. A 25-year-old female had regular 28 cycles. Which of these hormonal patterns will be seen during 21 to 25 of her cycle? Answer is increased estrogen and progesterone with low LH and FSH. So day 21 to 25, it corresponds to the luteal phase of a regular 28-day menstrual cycle. And during this phase, the ruptured follicle forms the corpus luteum, which secretes the progesterone and also produces moderate amount of estrogen. Progesterone is the dominant hormone in the luteal phase, and it prepares the endometrium for implantation. Elevated estrogen and progesterone, they exert negative feedback on the hypothalamic pituitary axis, leading to suppression of FSH and LH. The pattern showing low progesterone or high gonadotrophin are inconsistent with the post-ovulatory luteal phase physiology. Next, a 65-year-old woman presented with abdominal swelling and discomfort. USG showed ascites and a multiloculated, predominantly cystic swelling with papillary projections. CA125 was 1035 IU per ml, and the gross image is also given. Most likely diagnosis, answer is serous cystadenocarcinoma. Is a common epithelial ovarian carcinoma in postmenopausal women. Presentation is abdominal swelling, ascites, and image showing a multiloculated cystic mass with papillary projections, which is highly suggestive of malignancy. Markedly elevated CA125 levels, they support an epithelial ovarian origin, particularly the serous type. Granulosa cell tumor, that is the other options. Granulosa cell tumor, they are sex cord stromal tumors, often estrogen secreting, presenting with endometrial hyperplasia or abnormal uterine bleeding, and it is associated with inhibin elevation, not massive ascites or very high CA125. Sertoli Leydig cell tumors, they are androgen producing, causing virilization features. Imaging usually lacks papillary projections, and CA125 is typically not markedly elevated. Immature aderatomas, they arise from multiple germ layers and are usually solid with trabeculated appearance and are not typically associated with papillary projections, massive ascites, or very high CA125 levels. Next question. A primigravida suffers atonic postpartum hemorrhage during labor. After initial measures and medical management failed, what is the next best step of management that can be done in the labor room? Answer is balloon tamponade. Atonic postpartum hemorrhage that does not respond to uterine massage and ureterotonic drugs, they require prompt escalation to a minimally invasive labor room based intervention. Balloon tamponade using Bakri's balloon of a Foley's catheter or quantum catheter or Sengstaken Blakemore tube is inserted in the uterine cavity and inflated with normal saline about 200 to 500 ml. It controls bleeding by direct tamponade effect on open uterine sinuses and by stimulating uterine contraction. The balloon is typically kept for 4 to 6 hours, allowing stabilization and often avoids hysterectomy. And compression sutures and stepwise devascularization, they are surgical procedures requiring an operating theatre. And emergency hysterectomy, it is reserved for refractory life-threatening hemorrhage. And conservative measures and less invasive measures, they fail. Next question, a G2P1L1 suffers cord prolapse during labor. Cervix was 5 cm dilated and cord pulsations, they were present. Next best step in management, answer elevate buttocks, tilt the head back and fill the bladder. So cord prolapse with cord pulsations present, they indicate a live fetus with ongoing cord compression requiring immediate relief of the pressure. So elevating the buttocks and placing the patient in Trendelenburg's position or Nietzsche's position helps lift the presenting part of the cord. Filling the bladder with saline, that is Wego's method or bladder filling method, using a Foley's catheter provides upward pressure on the presenting part, reducing compression of the cord and improving the fetal blood flow. These measures, they are temporary but life-saving, buying time until definitive delivery, usually by cesarean section. Waiting and watching is inappropriate because continued compression can rapidly cause fetal hypoxia and death. Oxytocin is not used as immediate vaginal delivery is not possible here, and pushing the cord back and packing is avoided as it increases the trauma and worsens compression. Next, what is the order of closure in a mediolateral episiotomy? Answer is mucosa, muscle and skin. So this question is something very easy kind of question. So guys, these kind of easy questions, please don't make them wrong in the exams. Next one, a 35-year-old P2L2 woman presented with secondary amenorrhea for 1 year. She had elevated gonadotropin hormones, that is FSH 36 and LH 56, and decreased AMH. What is the likely diagnosis? Answer premature ovarian insufficiency. So secondary amenorrhea with elevated FSH and LH indicates hypergonadotrophic hypogonadism, pointing to ovarian failure rather than hypothalamic or pituitary causes. Very low AMH, it reflects severely depleted ovarian reserve, as AMH correlates with the number of primordial follicles. Premature ovarian insufficiency, it is defined as loss of ovarian function before the age of 40 years, characterized by persistently elevated FSH levels on at least 2 occasions 1 month apart. Next question. A primary gravida was prescribed Pritchard's regimen to manage preeclampsia. What is the total loading dose of magnesium sulfate given? So answer is 14 gram. Again, Pritchard's regimen, very important. So here the magnesium sulfate is given as a combined intravenous and intramuscular loading dose. The loading dose, it consists of 4 gram of magnesium sulfate, 20% given IV over 3 to 5 minutes. This is followed by 10 gram intramuscular, 50%, 5 gram in each buttock. Thus the loading dose is 4 gram IV plus 10 gram IM, that is 14 gram. And magnesium sulfate, it acts as a membrane stabilizer and neuroprotector, reducing neuromuscular transmission and preventing seizures in preeclampsia and eclampsia. Next, a resident is performing a maneuver in the labor room. Identify the procedure. Answer control code traction. It is used in third stage of labor to assist placental delivery. It is performed only when the uterus is well contracted, reducing the risk of uterine inversion. In modified Brand Andrews technique, one hand supports the uterus above the symphysis pubis, pushing it upward and backward, while the other hand applies steady downward traction on the clamped umbilical cord. This facilitates separation, descent, and expulsion of the placenta in a controlled manner. Control cord traction, as it is a component of active management of third stage of labor, along with ureterotonic administration and delayed cord clamping. And manual removal, it involves intrauterine hand insertion. Episiotomy is a perineal incision, and bimanual uterine compression is used for postpartum hemorrhage control. So all these features are not shown here. That is why these are the options which are excluded. Next, a P1L1 mother with BMI of 35 diagnosed with preeclampsia underwent LSCS. Ideal agent for prophylaxis of postpartum venous thromboembolism. Answer is low molecular weight heparin. So, a woman with obesity, preeclampsia, cesarean delivery has high risk of postpartum venous thromboembolism. Low molecular weight heparin is the drug of choice for prophylaxis in postpartum period, and it is given subcutaneously, has predictive pharmacokinetics, longer half-life, and a lower risk of osteoporosis and thrombocytopenia compared to unfractionated heparin. It is safe in pregnancy and lactation, and it does not cross the placenta. And others, they are not used. Next, a 28-year-old female who was diagnosed with carcinoma cervix presented with hydroureteronephrosis. Stage of the disease, answer is 3B. So, hydroureteronephrosis in CA cervix indicates ureteric obstruction due to pelvic wall involvement. According to the revised figure 2018 staging, Stage 3B includes extension to the pelvic wall with or without hydronephrosis or a non-functioning kidney. So again, guys, the staging of CA cervix is very important, and CA endometrium, that is also important. CA cervix and breast CA, all these are very important, guys. So stage 3A, it is limited to involvement of lower 1/3 of vagina without pelvic wall extension. 2A means it is extension to the upper 2/3 of the vagina without parametrial involvement. And stage 4A, it requires invasion of adjacent pelvic organs such as bladder or rectum. Next question, a 55-year-old woman presents with the following findings. She has history of 2 home births assisted by untrained eye. Which of these ligaments could have been injured? Answer is McEnroe's ligament. So, image and clinical history, it is suggestive of uterovaginal prolapse. McEnroe's ligament, which is the cardinal ligament, it is the chief support of the uterus, anchoring the cervix and upper vagina to the lateral pelvic wall. Repeated vaginal deliveries, especially home births conducted by untrained personnel, can cause weakening or injury to the cardinal ligaments, leading to uterine descent. And other options like round ligament. A round ligament mainly maintains the uterine in anteversion and does not provide major pelvic support. Broad ligament is a peritoneal fold and not a primary supportive structure of the uterus. And inguinal ligament, it is unrelated to uterine support and plays no role in pelvic organ prolapse. Next, a 45-year-old woman presents with delayed cycles and heavy heavy bleeding for the past 1 year. And USG showed an endometrial thickness of 16 mm. Next best step in management, answer is endometrial biopsy. So, in perimenopausal women with abnormal uterine bleeding, the priority is to rule out endometrial hyperplasia or carcinoma. So, endometrial thickness which is more than 10 mm in perimenopausal women, it is considered abnormal and warrants histopathological evaluation. Endometrial biopsy provides tissue diagnosis which is essential before initiating a definitive or hormonal therapy. Next question, a 30-year-old pregnant female with history of enlarged inguinal lymph nodes and toxoplasmosis 5 years ago tested positive for IgG to toxoplasmosis. She should be counseled that there is no risk to the fetus and pregnancy can be continued. So, IgG positivity for toxoplasmosis indicates a past infection with the development of long-term immunity. Next question, a 35-year-old lady with amenorrhea presents with galactorrhea. She is diagnosed with pituitary adenoma. Most probable cause of the condition, answer is decreased GnRH. A pituitary adenoma causing galactorrhea and amenorrhea is most commonly a prolactinoma. And excess prolactin, it exerts an inhibitory effect on the hypothalamus, leading to suppression of gonadotrophin releasing hormone. So, reduced GnRH, it results in reduced secretion of FSH and LH, causing amenorrhea, anovulation, and infertility. Increase in LH surge or rise in FSH and LH, it is incompatible with hyperprolactinemia-related hypogonadism. And downregulation of the estrogen receptors, it is not the primary mechanism because the core defect lies in the hypothalamic GnRH suppression due to the high prolactin levels. And next question, a 46-year-old nulliparous woman with history of irregular periods presents with amenorrhea for 2 months and is positive urine UPT. And how will you accurately assess the gestational age? Answer is crown rump length. So in early pregnancy, especially with irregular menstrual cycles, dating based on LMP is unreliable. Crown rump length is done, which is measured on the first trimester USG, is the most accurate method for assessing gestational age. The CRL provides dating accuracy of about plus or minus 5 to 7 days in the first trimester. Then biparental diameter and abdominal circumference, they are better suited for second and third trimester assessment and fetal growth monitoring. And gestational sac diameter, it is less accurate than CRL and is used only when the embryo is not yet visible. Next question, a 55-year-old postmenopausal woman presents to OPD for routine BP checkup and her BP is 170/100. She complains of bloodstained discharge per vagina. Next best step is answer immediate pelvic examination and transvaginal sonography and pap smear. So postmenopausal bleeding or bloodstained discharge is never normal and requires urgent evaluation. Immediate pelvic examination may reveal abnormalities such as enlarged uterus, abnormal cervix or adnexal mass. And transvaginal USG, it is used to assess the endometrial thickness and detect pathologies like endometrial polyp or carcinoma. And endometrial thickness, which is more than 4 mm, indicates the need for endometrial biopsy. Pap smear is essential to screen for cervical pathology and to exclude the cervical cancer. And the hypertension, it is a recognized risk factor for endometrial carcinoma along with obesity, diabetes, PCOS, older age, early menarche, late menopause, nulliparity and long-term contraceptive use. Reassurance, it is inappropriate because postmenopausal bleeding always warrants evaluation. And referral to a cardiologist is not the immediate priority as BP, though high, is not an acute emergency in this setting, and direct hysterectomy without establishing a diagnosis, it is incorrect, and so the priority is to identify the cause and to exclude the malignancy. Next question, a 30-year-old female came with history of chronic abdominal discomfort for past 1 year. MRI shows the following. Diagnosis, answer is adenomyosis. So MRI shows an enlarged globular uterus with thickening of the junctional zone, which is characteristic of adenomyosis. It is defined by the presence of endometrial glands and stroma within the myometrium, leading to diffuse uterine enlargement. Typical MRI finding is diffuse low intensity junctional zone thickening of more than or equal to 12 mm, which strongly suggests adenomyosis. And clinically it presents with chronic pelvic pain, dysmenorrhea, menorrhagia, dyspareunia and backache with a soft, tender, symmetrically enlarged uterus on examination. Next question, a G2P1L1 with history of previous C-section presented in active labor. During trial of labor, there was fetal bradycardia and maternal tachycardia. Persistent suprapubic pain between contraction was also noted. On examination, cervix was 8 cm dilated and vertex was at -1 station. Next best step of management, answer is emergency LSCS. So the combination of previous C-section, persistent suprapubic pain between contractions, maternal tachycardia, fetal bradycardia, all are highly suggestive of scar dehiscence or impending uterine rupture during TOLAC. So persistent pain between contractions is the key warning sign of uterine scar compromise, and cervix is 8 cm dilated and head is at -1 station, indicating the presenting part is not engaged, marking instrumental delivery unsafe, and continuing labor or waiting risks the complete uterine rupture with severe maternal and fetal morbidity. So emergency LSCS is the safest and definitive step here to prevent uterine rupture and fetal compromise. Next question, a patient presents with 2 months of amenorrhea with enlarged uterus. On examination, there is darkening of areola, prominent Montgomery tubercles, linea nigra, and there is bluish discoloration of vagina. How would you categorize these signs? Answer, probable. So amenorrhea, breast changes, dark areola, Montgomery tubercles, and linea nigra. Their subjective features felt or noticed by women and considered as presumptive signs. Bluish discoloration of vagina, which is the Chadwick sign, and uterine enlargement, they are objective. Physical findings detected on examination. The presence of uterine enlargement, which is clinically detectable change, upgrades the findings from presumptive to probable signs of pregnancy. And confirmatory signs, they require direct evidence of the features such as ultrasound visualization of the gestational sac or embryo, fetal heart sounds or fetal movements felt by the examiner. Pseudo-pregnancy, it's a psychological condition with symptoms mimicking pregnancy, but no true pregnancy exists in that case.
Pediatrics. But before that, I'd like to inform you guys that the PDF of this video is available at a very nominal price, and also the 8 years PYQ compilation is also available at a very nominal price, guys. You can check out my Telegram channel or my super profile link for further details. And yeah, now quickly moving on to this. First one, a 12-year-old child with CKD presents with bowing of legs. He also had minimal sun exposure. Lab investigations reveal serum calcium of 7, serum phosphate of 6.9, alkaline phosphatase of 370 and low vitamin D levels. What is the most appropriate next step in management? Answer is vitamin D and calcium supplementation. So in case of CKD, it leads to reduced renal activation of vitamin D, resulting in low calcium absorption, hypocalcemia, and secondary hyperparathyroidism. Clinical bowing of legs with raised alkaline phosphatase indicates renal rickets, and low vitamin D and minimal sun exposure, it worsens the calcium deficiency. So calcium supplementation, it corrects the hypocalcemia, while it activates vitamin D and improves the intestinal calcium absorption, suppressing the parathyroid hormone excess and enhances the bone mineralization. So next question, a neonate was screened and was found to have congenital hypothyroidism. T3 and T4 levels were decreased and there was no radioactive trace or uptake, but thyroid gland was normal on USG. Most likely cause is, answer, defect in iodine transport. So low T3 and T4 with structurally normal thyroid gland on USG indicates a functional rather than anatomical problem. So absent radioactive tracer uptake suggests the failure of iodide entry into the thyroid follicular cells. And sodium iodide symporter, that is NIS defect, it prevents the iodide transport into the gland, leading to hypothyroidism despite normal gland size and location. Next question, an unusually tall 14-year-old boy with extremely long limbs came to the ophthalmologist with complaints of diminution of vision. On examination, there was bilateral subluxation of lens, that is ectopia lentis. Which of the following defects is found in this patient? Answer is fibrillin 1. So, tall stature, long limbs and ectopia lentis, they are all classic features of Marfan syndrome. It is caused by a mutation in fibrillin 1, an extracellular matrix protein which is essential for connective tissue integrity. So, defective fibrillin, it weakens the ciliary zonules, leading to bilateral lens subluxation. Others like COL5A2 mutations, they are associated with the Ehlers-Danlos syndrome. LDLR gene defects, it causes familial hypercholesterolemia, and PLOD1 gene mutations, they are linked to kyphoscoliotic Ehlers-Danlos syndrome. Next, a primary gravida at 34 weeks of gestation was diagnosed as HIV positive, for which ART was initiated. She had a viral load of 1200 copies per ml. The baby of 2.5 kg was delivered at term through vaginal delivery and baby was healthy. Next step as per our setup is syrup nevirapine plus zidovudine for 12 weeks with exclusive breastfeeding. Diagnosis of HIV at 34 weeks implies late initiation of ART, leading to inadequate viral suppression at delivery. Maternal viral load more than 1000 copies per ml classifies the newborn as high-risk infant for vertical transmission. High-risk infants, they require dual ART prophylaxis with nevirapine and zidovudine. With exclusive breastfeeding, dual prophylaxis is continued up to 12 weeks. Single drug prophylaxis for 6 weeks is reserved for low-risk infants with suppressed maternal viral load. Stopping breastfeeding is not recommended in the programmatic Indian setting because of the higher risk from the replacement feeding. Next, a newborn presents with deformity in all four limbs and there was no index finger in the right hand. Likely diagnosis is amniotic band syndrome. So absence of index finger along with multiple limb deformities, it is a disruptive defect, not a primary malformation. Amniotic band syndrome, it results from constricting strands of amnion that entangle the fetal parts, causing amputation, deformity or tearing of previously normal structures. The condition is sporadic and commonly involves the limbs and digits, often asymmetrically, and CTEV, it is an isolated foot deformity. It does not explain the missing digits or involvement of all four limbs. Next, a 6-year-old boy is brought to the emergency department with fever and seizures. Most appropriate immediate treatment for this child is diazepam. So fever, the acute seizure in a child is most consistent with febrile seizure requiring rapid seizure termination. Diazepam, which is a benzodiazepine, is the first line immediate drug because of its rapid onset of action. It enhances the GABA-mediated chloride channel opening, reducing the neuronal excitability and quickly aborting the seizures. Next, a mother is feeding her 7-month-old baby thick homemade cereal as supplementary feeds besides breastfeeding. What is the appropriate volume and frequency of feeds for this child in a period of 24 hours based on the infant and young child feeding guidelines? So answer is half to 1 katori 3 times a day. A 7-month-old infant, it falls in the 7 to 8 month age group as per the infant and young child feeding guidelines. So recommended feeding is 3 complementary meals per day along with frequent breastfeeding. Amount per meal, it should be increased gradually up to 2/3 of a 250 ml bowl, which corresponds to approximately half to 1 katori. Higher feeding frequencies, they are not recommended at this age. So moving on to next subject, dermatology. A 45-year-old male presents with complaints of pruritic rash over the elbows, knees and buttocks. He recently visited the gastroenterology OPD and was found to be sensitive to gluten. Skin biopsy showed IgA immunofluorescence. Most probable diagnosis is answer dermatitis herpetiformis. So intensely itchy lesions on the extensor aspect of elbow and knees, the hallmark clinical cue of dermatitis herpetiformis. Granular IgA deposits along the basement membrane or direct immunofluorescence is a characteristic feature. And pathophysiology involves antibodies against the epidermal transglutaminase, leading to neutrophilic microabscesses in the dermal papillae. Strong association with gluten-sensitive enteropathy explains the GI link. The other options, the epidermolysis bullosa, it's a genetic blistering defect presenting from childhood. Bullous pemphigoid, it shows linear IgG deposition and typically affects the elderly. And pemphigus vulgaris, it's an intraepidermal blistering disease with mucosal involvement and IgG antibodies. Next, a 48-year-old male presented with asymptomatic lesion on the right cheek with central atrophy, which has been slowly progressive over the last 2 years. Chest X-ray reveals apical calcification. How will you confirm the diagnosis? Answer is PCR. A slowly progressive painless plaque with central atrophy and serpiginous margins. It is suggestive of cutaneous TB. Apical calcification on chest X-ray indicates the healed pulmonary TB, supporting the reactivation or spread to skin. And cutaneous lesions are paucibacillary. So direct staining is often negative. PCR detects the mycobacterial DNA with high sensitivity. Next question. An 8-year-old girl presented with follicular hyperkeratotic papules over the elbow, knees and buttocks. She has dry skin and lustreless hair. Which of the following is the next step in evaluation? Answer is ocular examination. So follicular hyperkeratotic papules over the extensor surfaces, dry skin and lustreless hair, they're all characteristic of rhinoderma, a cutaneous manifestation of vitamin A deficiency. It is commonly presenting as early ocular involvement, making eye assessment crucial to detect the conjunctival cirrhosis, Bitot spots or keratomalacia. The earliest functional abnormality is defective dark adaptation, that is nyctalopia, which may precede the visible eye signs. Next question. A female presented with patches in the oral cavity with complaints of burning sensation after taking a drug for 6 months. Symptoms worsened on eating spicy food. Which drug is most likely to cause this condition? Answer is beta blocker. So reticular white patches in the oral cavity with burning sensation aggravated by spicy foods. It is characteristic of oral lichen planus. Chronic drug exposure can cause the lichenoid drug eruption, which clinically and histologically mimics the lichen planus. Beta blockers, they are among the most commonly implicated drugs causing drug-induced oral lichen planus. And lithium, the other options, the lithium, it is less frequently associated and it usually causes mucocutaneous adverse effects. Fluconazole, it is used to treat oral candidiasis and it does not produce reticular white lesions. Ciprofloxacin, it commonly causes GI or tentin related adverse effects rather than lichenoid oral lesions. Next question. A 62-year-old farm labor presented with a swelling over the right foot for 2 years, which was initially asymptomatic but now has serous discharge and occasional black granules. KOH mount of the discharge will reveal which of the following. Answer septate hyphae of 4 to 5 microns. So guys, in this, it is lichenoid lesions are produced in this person, and the most common cause here, the answer is beta blocker. It's lichenoid drug eruption which is seen here. Next, a 68-year-old farm labor presented with a swelling over the right foot for 2 years, which was initially asymptomatic but now has serous discharge and occasional black granules. KOH mount of the discharge reveals which of the following. Answer septate hyphae of 4 to 5 microns. So chronic foot swelling with multiple draining sinuses and black granules. It is characteristic of mycetoma. Presence of black granules points towards mycetoma, commonly caused by Madurella mycetomatis. And on KOH mount, crushed grains, they show slender septate fungal hyphae measuring 4 to 5 microns, which is diagnostic of eumycetoma. And the other options like arthropole, they are typical of dermatophyte infections. Budding yeast with pseudohyphae, it is seen in Candida infection. And hyphae with flower-like conidia arrangement is seen in sporotrichosis. Next, a patient presents with an asymptomatic macular lesion since childhood. Diascopy was inconclusive and wood lamp examination showed white accentuation. What is the likely diagnosis? Answer nevus depigmentosus. So stable asymptomatic macular lesion since childhood. It points towards a congenital non-progressive hypopigmented disorder. Wood lamp examination showing white, that is off-white accentuation. It is characteristic of nevus depigmentosus, unlike the chalky white fluorescence of vitiligo. And diascopy being inconclusive, it helps exclude the vascular causes such as the nevus anemicus. Next question. A child presents with trigeminal neuralgia associated with painful vesicular lesions around the mouth. On eloculation of cell culture, multinucleated giant cells with intranuclear inclusions were seen. Causative organism is herpes simplex virus.
First question, a 35-year-old man is brought to psychiatric emergency with bizarre symptoms. A social worker reports that the man lives in a nearby village that was recently hit by earthquake. The man appears confused and does not know how he traveled 110 kilometers to the city. He is unable to recollect his personal details and has no history of any substance abuse or head trauma. Family members are worried about the patient. Most likely diagnosis is answer dissociative fugue. So it is characterized by sudden travel away from home, often following severe stress or trauma, such as a natural disaster. The patient shows inability to recall personal identity and confusion about how he traveled, which are the hallmark clinical cues. Memory loss mainly involves the autobiographical information, while general cognitive functions, they are preserved. Dissociative amnesia, so the other options also, you need to know how to rule out them, because that is again, these the other options, they can become potential questions coming up in next exams. So you need to have an idea about them as well. So dissociative amnesia, it presents with inability to recall important personal information related to stress but without purposeful travel. Then transient global amnesia, it is due to temporal cerebral ischemia, causing acute anterograde amnesia, usually in older individuals without loss of personal identity or long distance travel. Then the dissociative identity disorder, it involves two or more distinctive personality states with identity switching rather than sudden travel and global autobiographical amnesia. Next question, a 21-year-old female presents with amnesia for an event that occurred 2 weeks ago. She reports having flashbacks of the event repeatedly. The diagnosis is answer acute stress disorder. So it occurs after exposure to an exceptional stressor such as death of a loved one or a severe accident. Symptoms include intrusive memories and flashbacks, amnesia, 4 aspects of the event, negative mood, avoidance and hyperarousal. The time frame is very, very important. Symptoms develop within days to weeks after trauma, and it can last up to 1 month. And the other options, post-traumatic stress disorder, it persists for more than 1 month after the traumatic event. And adjustment disorder, it does not present with intense trauma-related symptoms like flashbacks and dissociative amnesia. It is associated with identifiable stressors. And then dissociative disorder, it involves disruption of identity or memory but lacks the full spectrum of trauma-related intrusive and arousal symptoms. Next is schizophrenic patient responded well on haloperidol for past 2 years, presented with orofacial dyskinesia, coriform and tick-like movements and possible dystonia. Probable diagnosis and treatment, answer tardive dyskinesia and valbenazine. So tardive dyskinesia, it occurs after months to years of antipsychotic use, especially typical antipsychotics like haloperidol. It is caused by dopaminergic D2 receptor supersensitivity in the basal ganglia. And clinical clues, it includes the orofacial dyskinesis, coriform tick-like involuntary movements and sometimes dystonia. Then so VMAT2 inhibitors such as valbenazine, they are the treatment of choice as they reduce the presynaptic dopamine release. Next question, a 30-year-old male reports that whenever he is outside, the birds communicate to him through flapping of wings and chirping. He believes that God sends him messages through the birds guiding him to safety. These features are characteristic of answer delusional perception. So it is a normal sensory perception that is given a private, illogical and fixed meaning. The perception itself is real, that is birds chirping and flapping, but the interpretation is delusional, believing divine messages are being sent. It's a first-rank symptom of schizophrenia described by Kurt Schneider. And the other options, yes, you need to have an idea about them as well. So moving on to next one, a 68-year-old female with breast cancer with metastasis present with breathlessness and poor health. The patient is awake and anxious. Oncology team believes that aggressive chemotherapy and radiotherapy will not be helpful. However, her daughter insists on trying everything including ICU stay and mechanical ventilation. How should a doctor handle this? Answer, convene a family meeting to discuss care goals and clarify the patient's preferences. So the patient has advanced metastatic disease with poor prognosis where aggressive interventions, they are unlikely to provide benefit. An early structural family meeting helps align care with the patient's values, wishes and goals, especially when there's a conflict between medical judgment and family expectations. This approach, it promotes the shared decision making, reduces unrealistic expectations and supports ethical end-of-life care. So next question, a friend of Mr. K, an MBA student, describes him as being focused on rules and being very rigid. He often delays submission of assignments due to wanting them to be perfect, and he also reports that Mr. K keeps items that are worn out even if they don't hold any sentimental value, and Mr. K thinks himself to have high moral values. The friend describes that Mr. K is often called rigid during adolescence, and when confronted with these facts, Mr. K denies them outright. What is the most likely personality disorder? Answer, obsessive compulsive personality disorder. So it is marked by perfectionism, rigidity and preoccupation with rules, details and orders related to inefficiency and delayed task completion. And Hoarding of worn out objects without sentimental value reflects difficulty discarding items due to perceived need, and individuals they often have excessive consentness and high moral standards and are ego-syntonic, explaining denial when confronted. And onset is typically in adolescence or early adulthood with a long-standing pattern of behavior. So moving on to radiology questions, the newborn is admitted to NICU after 24 hours with severe respiratory distress. The diagnosis from the given X-ray is answer congenital diaphragmatic hernia. So the X-ray shows intrathoracic bowel shadows with mediastinal shift, which is a classical radiological clue of congenital diaphragmatic hernia. It is a birth defect in the diaphragm, allowing abdominal organs to herniate into the chest cavity. This leads to lung compression and pulmonary hypoplasia, causing severe respiratory distress soon after birth. The most common type is Bushra-like hernia, a posterolateral defect usually involving the left side. So congenital, other options, the congenital pulmonary airway malformation, it presents as cystic or non-cystic lung lesions from early airway maldevelopment. Loculated pneumothorax, it shows as localized pleural air collection without bowel shadows, and congenital lobar emphysema, it results from a check valve mechanism causing progressive hyperinflation of a lung lobe, not bowel lobes in thorax. Next question, a 55-year-old male presented with a pulsative swelling in the neck. The swelling was compressible and refilled on removing of pressure. The digital angiography image is given. Identify the condition. So here the answer is carotid body tumor. Its features of painless, slow-growing pulsatile lateral neck mass with compressibility and slow refilling. It's characteristic of carotid body tumor. Angiography shows playing of the internal and external carotid arteries at the common carotid artery bifurcation, known as the Liar's sign. And the others, like carotid body tumor, it's a paraganglioma arising from the chemoreceptor cells of the carotid bulb. The tumor is usually firm, moves side to side but not vertically, and it may be associated with a bruit, and often it presents in the 5th decade and is usually benign. So the carotid, other things like carotid aneurysm, it presents as pulsatile neck swelling but lacks carotid bifurcation splaying. Strawberry hemangioma, it's a capillary hemangioma of infancy appearing at or shortly after birth. And AV fistula, it represents an abnormal communication between an artery and vein, producing different angiographic flow patterns. Next, what is the most appropriate statement regarding the given investigation? Answer is non-invasive and used to diagnose uretropelvic junction obstruction. So here the image is intravenous urography. It is a non-invasive radiographic investigation using intravenous contrast medium to visualize the renal parenchyma, pelvic calcial system, ureters and urinary bladder. It is commonly used to identify ureteric obstruction, especially uretropelvic junction obstruction, by demonstrating delayed excretion and dilation. It helps to assess the renal function, cause of ureters, papillary necrosis, and also anatomical variants such as horseshoe kidney. And bladder calculate treatment, it requires endoscopic or surgical intervention, not IVU. And bladder cancer, it is diagnosis relies on cystoscopy with biopsy and not IVU again. And percutaneous access to the pelvic calcial system is required for percutaneous nephrostomy and not IVU. Next question, a 50-year-old female has complaints of right flank pain since the past 6 months. Identify the lesion. Answer is right renal neoplasm. So clinical history of chronic right flank pain with imaging showing a right renal mass is suggestive. And the renal neoplasm, it is common in individuals between 50 to 70 years. And the presentation typically includes flank pain, palpable flank mass or hematuria. CT is commonly used for evaluation of a renal mass. And on NCCT, lesions show soft tissue attenuation, while larger lesions may show areas of necrosis and calcification. In case of gallbladder carcinoma, that's the other options. It presents with right hypochondrial symptoms and gallbladder mass, and retroperitoneal tumors, they are not confined to the renal outline. And liver abscess, it presents with fever and liver-related findings rather than a renal mass. Next question, a female presented with recurrent headaches. Identify the lesion in the given MRI. Answer is meningioma. So MRI shows a well-defined extraaxial mass with homogeneous enhancement. Presence of a dural tail sign extending from the lesion along the dura mater is characteristic of it. And meningioma often arises from meningocytes or arachnoid capsules of the meninges, more common in females and is associated with an F2 mutation. Common presentations include headache, seizure, paresis, or change in mental status. Other options like glioma. Glioma is an intraaxial tumor without dural involvement. Ependymoma, they usually arise from the ependymal liming of ventricles and are typically intraventricular. And pilocytic astrocytoma, it's a benign astrocytoma seen mainly in children and young adults, often showing a cystic lesion on MRI. Now moving on to anesthesia questions. A 40-year-old female on administration of a neuromuscular blocker developed erythema, flushing of face, neck, tongue and hypotension. Which of the following drugs is responsible? Answer atracurium. So clinical features like erythema, flushing and hypertension, they indicate histamine release. Atracurium, which is a benzyl isoquinoline non-depolarizing muscle relaxant, it is a potent histamine releaser. And steroid relaxants, they have minimal histamine releasing potential. Cis atracurium, it's an isomer with negligible histamine release. Next question. Following a building collapse, a male patient was brought with a copious amount of debris in the mouth. Following procedure was done. Which of the following statements regarding the procedure is true? So here the answer is it should be followed by tracheostomy. So here the image is of a cricothyrotomy, an emergency surgical airway. It's a temporary airway and may be converted to tracheostomy to prevent complications like subglottic stenosis and laryngeal injury. Needle cricothyrotomy, it allows only short-term ventilation and work of breathing is reduced due to bypassing upper airway resistance. Next question. A 50-year-old male with COVID developed ARDS and is on mechanical ventilation with a PaO2 by FiO2 ratio of 100. Most appropriate ventilator strategy for this patient? Answer high PEEP and low tidal volume. So PaO2 by FiO2 ratio of 100 indicates severe ARDS. Low tidal volume ventilation prevents barotrauma and volutrauma. High PEEP prevents alveolar collapse and improves oxygenation, and this strategy aligns with lung protective ventilation principles. Next, general anesthetic, sevoflurane and succinylcholine were administered to a patient undergoing abdominal surgery. Postoperatively, patient develops persistent muscle contractions, hypothermia and tachycardia. Which of the following drugs is life-saving in this situation? Answer dantrolene. So the presentation, it is characteristic of malignant hypothermia. It is triggered by volatile anesthetics and succinylcholine in genetically susceptible individuals. It is caused by RYR1 receptor mutation leading to uncontrolled calcium release from sarcoplasmic reticulum. Dantrolene, it inhibits the calcium release, reversing the muscle rigidity and hypermetabolism.
Now, quickly moving on to the details of this video. First one, a 58-year-old male, known case of diabetes mellitus and hypertension, presents with nasal bleeding. If the initial conservative management such as nasal packing was not successful in controlling the bleed, which of the following arteries should most importantly be ligated to control the bleed? Answer is sphenopalatine artery. So it is the primary arterial supply to the posterior nasal cavity and is the main contributor to the Kisselbach's plexus and the posterior nasal septum. Persistent epistaxis not controlled with nasal packing, it is usually because of bleeding from this vessel, making ligation of the sphenopalatine artery the preferred definitive step. Little's area, that is the Kisselbach's plexus, it is the commonest site of epistaxis. And this plexus, it is formed by contributions from the anterior ethmoidal, superior labial, septal branch of sphenopalatine and greater palatine arteries. The other options like anterior ethmoidal artery, it mainly supplies the anterior superior septum. Bleeding here usually responds to conservative measures, and posterior ethmoidal artery, it rarely causes epistaxis and it is difficult to access surgically. The greater palatine artery, it contributes minor supply to the septum and is not typically responsible for severe refractory nosebleeds. So hierarchy of vessel ligation and epistaxis, first is the sphenopalatine artery, the first and most important vessel to ligate. Then is the internal maxillary artery. The greater palatine artery is a branch of this vessel, so that. Then external carotid artery, anterior ethmoidal artery, and then the posterior ethmoidal artery. So why the sphenopalatine artery is ligated first? It is because it is accessed using a transnasal endoscope at the sphenopalatine foramen located at the posterior end of the middle turbinate and supplies the posterior septum, which is the usual source of refractory epistaxis. If the bleeding is persisting, then yes, internal maxillary artery is ligated at the pterygopalatine fossa. If still uncontrolled, then the external carotid artery is ligated above the origin of the superior thyroid and artery. And if the bleeding arises superior to the middle turbinate, then the anterior and posterior ethmoidal arteries should be ligated through a Lynch incision in the medial wall of the orbit. Next question. A 20-year-old patient presents with recurrent ear discharge and conductive hearing loss with 30 decibel loss. Which of the following is the management of choice? Answer is myringoplasty. So all ossicles are intact, so there's no need for ossicular reconstruction. And the management of choice in this setting is myringoplasty, which is also known as the type 1 tympanoplasty. So myringoplasty, it involves the closure of a perforation in the pars tensa by placing a graft either under, that is underlay technique, or over, that is the overlay technique, the remaining tympanic membrane. Common graft materials include the temporalis fascia, which is the most common, then the areola fascia, then the tragal perichondrium, then the cartilage vein and periosteum. In the underlay technique, the graft is placed medial to the annulus, and in the overlay technique, it is placed lateral to the annulus. And the graft remains medial to the malleus in both the techniques. Modified radical mastoidectomy, atticotomy, and exploratory tympanotomy, they are reserved for conditions such as cholesteatoma, ossicular erosion, or attic disease.
Next, an industrial worker presented with hearing loss. Renee's was negative on left side and positive on right side. Weber's was lateralized to the left side. Pure tone audiometry was done with results as shown here. And choose the most appropriate diagnosis. Answer is left-sided conductive deafness. So Renee's test on the left indicates conductive hearing loss in that ear. And Weber's, which is lateralized to the left, suggests the left ear is worse ear for air conduction, which happens in conductive hearing loss. And pure tone audiogram here shows bone conduction within normal limits, meaning the sensory neural pathway is normal. And air conduction is elevated, meaning that impaired transmission through the external or middle ear. An airborne gap is clearly present, which is diagnostic of conductive deafness. And combined tuning fork test and audiogram findings, it leads to a case of left-sided conductive deafness. So this is again the symbols which we use. So again a very important one. Yes, and tuning fork test, again this is very important. The Renee's, Weber's, absolute bone conduction, Schwabach, Bing and Kelly. Next, audiogram patterns in different hearing disorders. Again, this is also very important. So, conductive hearing loss, airborne gap will be present in case of sensory neural hearing loss. Both AC and BC will be abnormal, but there is no airborne gap. Mixed hearing loss, both AC and BC are abnormal, airborne gap is present. And in case of presbycusis, ototoxicity and noise-induced hearing loss, there will be downsloping, that is descending audiogram. In case of early stages of Meniere's disease, there will be upsloping or ascending audiogram. And in case of congenital hearing loss and cochlear otosclerosis, there will be U-shaped, trough-shaped or cookie bite audiogram. And in case of early cases of noise-induced hearing loss, there will be acoustic dip at 4000 Hz. In case of otosclerosis, there will be the Karhart notch, that is the dip at 2000 Hz. Next, a 75-year-old male smoker presents with complaints of hoarseness of voice and difficulty in swallowing. He is diagnosed with laryngeal carcinoma and undergoes surgery. What is the surgical procedure? Answer: total laryngectomy. So here the image shows a permanent tracheal stoma, which is characteristic of total laryngectomy, where the entire larynx is removed and trachea is brought out to the skin for breathing. And total laryngectomy, it includes the removal of the larynx, hyoid bone, pre-epiglottic space, traps muscles, and often one or more rings of trachea. And the pharyngeal wall is reconstructed and a tracheal stump is sutured to the skin to allow respiration. And indications are T3 and T4 laryngeal cancers or thyroid or cricoid cartilage invasion. And then in case of bilateral arytenoid involvement or posterior commissure lesions, or in case of failure of radiotherapy or conservation energy, or in case of transglottic tumors with cord fixation, and it is contraindicated in distant metastasis. And partial laryngectomy, it preserves the voice, while tracheostomy is only for airway access and does not remove the larynx. Next question, a male child in his second decade presents with recurrent profuse nasal bleeding in the right nasal cavity and right nasal obstruction. Endoscopy shows a globular mass in the right nasal cavity occupying the posterior choana and nasopharynx. MRI shows anterior bowing of the posterior wall of the maxillary sinus. What is the diagnosis? So here the answer is juvenile nasopharyngeal angiofibroma, that is JNA. It is usually presenting in a male adolescent with recurrent profuse epistaxis and unilateral nasal obstruction, which is classic. And a benign but locally invasive vascular tumor is seen predominantly in adolescent males, and it is believed to be testosterone dependent. Endoscopy shows a lobulated vascular mass in the posterior nasal cavity and nasopharynx, strongly supporting the diagnosis. MRI shows anterior bowing of the posterior wall of the maxillary sinus, that is the Holbein-Miller sign or the antral sign. It is pathognomonic of angiofibroma, and the tumor originates near the sphenopalatine foramen and it can extend to the nasal cavity, nasopharynx, paranasal sinus, cheek, pterygopalatine fossa, and skull base. The biopsy is usually avoided because of the higher risk of profuse bleeding, and surgical excision is the treatment of choice. Preoperative embolization may reduce the intra-op bleeding. So antrochoidal polyp, main etiological factors are infection and allergy, and is usually seen in children, and it usually affects the site of origin is the mucosa of the maxillary antrum, and features are it's usually single unilateral, and unilateral nasal obstruction becomes bilateral when it slowly grows posteriorly and obstructs the opposite choana, and mucoid nasal discharge will be there, hyponasal voice will be there, and findings, it grows posteriorly and is often missed on anterior rhinoscopy. In case of posterior rhinoscopy, there will be a globular mass filling the choana or nasopharynx, and investigations, nasal endoscopy will show a pale gelatinous pedunculated polyp, and in case of NCCT, detailed paranasal sinus anatomy will be seen, and primary diagnostic tool is NCCT. Treatment of choice is FES, that is the functional endoscopic sinus surgery. Next, identify the structure marked with the white arrow. So answer is piriform sinus. So image is barium swallow study of the hypopharynx, and the location of the arrow corresponds to the piriform sinus, which lies on either side of the laryngeal inlet. And the piriform sinus, it extends from the pharyngoepiglottic fold superiorly to the upper end of esophagus inferiorly. It is bound laterally by the thyroid membrane and thyroid cartilage and medially by the araepiglottic fold. It serves as the lateral food channel during swallowing and may show barium pooling in imaging. The internal laryngeal nerve, it runs submucosally in its lateral wall, making it an important anatomical region for referred ear pain and foreign body lodgement. Next is 2-year-old child was brought to emergency room following choking on a peanut. The child was unresponsive. Next step for management is chest compression. So an unresponsive choking child is managed by immediately activating the emergency response system and beginning the CPR, starting with 30 chest compressions. And the chest compressions, they generate enough intrathoracic pressure to attempt to dislodge the obstructing foreign body while maintaining the circulatory support. So after compression, the airway is opened and checked for any visible foreign body which may be removed. And 2 rescue breaths, they are attempted, and if they fail and the obstruction persists, then CPR cycles are continued. Abdominal thrusts and back slabs, they are only used in conscious children with severe obstruction and not in unresponsive child. Intubation, it shouldn't be done as the next step because establishing chest compression takes priority in unresponsive choking scenario. Next, boy sustained a fracture and an x-ray was done. The lateral x-ray of the nasal bone showed the nasal bone fracture. And which forceps is used for immediate correction? Answer is Walsham. So here the image shows the nasal bone fracture, and the Walsham forceps, these forceps is specifically designed to reposition displaced nasal bones during immediate correction before edema develops. And nasal fractures, they most often result from direct trauma, and they are primarily diagnosed by clinical examination. And management includes close reduction using appropriate instruments and external splints. So other ENT forceps shown in the image, they have different uses such as anterior nasal spacking, septum fracture reduction, foreign body removal or Calvelix procedures, but not nasal bone reduction. So different forceps and their uses. Walsham is used for reduction of nasal bone fracture. Ashes is used for nasal septal fracture reduction. Then Goldman septal displacer, it is used for displacing and exposing the nasal septum during SMR septoplasty. Tilly's for mainly used for anterior nasal packing. Then Bionets, it is for removal of foreign bodies from ear and nose. And Lux forceps, it is used in Calvel-Luke procedure, submucosal resection and polypectomy. So these are the forceps. So next, moving on to Ophthalm. Regarding different grades of binocular single vision, which of the following is correct? So figure 1 describes simultaneous macular perception and figure 2 describes fusion. So binocular singular vision, it is the ability to perceive a single image using both the eyes, and simultaneous macular perception refers to perception of image from both the eyes at the same time, even if they are not fused into one image. And fusion occurs when the brain combines two similar retinal images into a single unified perception. Next, a patient with bullous keratopathy has corneal gutter in the other eye. Most likely diagnosis is Fuchs endothelial dystrophy. So Fuchs endothelial dystrophy, bullous keratopathy, results from endothelial cell failure leading to stromal and epithelial edema with bulla formation. Presence of corneal gutter in the fellow eye is a classic early sign of Fuchs endothelial dystrophy indicating bilateral endothelial involvement. Condition is generally bilateral, progressive and presence in middle to older age. And the other options like trachoma, it primarily causes conjunctival scarring and pannus. Keratoconus, it involves the stromal thinning and ectasia. And herpes keratitis, it causes corneal inflammation and scarring. Next, indications of the given procedure. Answer is keratoconus. So the image shows intracorneal stromal ring segment, a procedure which is used to manage corneal ectasia. And keratoconus, it is a progressive bilateral corneal ectatic disorder characterized by stromal thinning, cortical protrusion and irregular astigmatism. So intracorneal stromal ring, it helps by flattening the stroma, reducing the irregular astigmatism and improving the visual acuity, especially in patients intolerant to contact lens. Next question, a 65-year-old male came with complaints of decrease in vision. There were white spots on the anterior lens surface seen during slit lamp examination. What is the diagnosis? Answer is pseudo-exfoliation syndrome. So it is an age-related degenerative disorder commonly seen in elderly individuals. It is characterized by deposition of grey white fibrillary material derived from abnormal extracellular matrix metabolism, and the deposits are seen on anterior lens capsule, pupillary margin and iris, appearing as flaky material on slit lamp examination. Accumulation in the anterior chamber angle can impair the aqueous outflow, increasing the risk of secondary open-angle glaucoma. And iris typically presents with ocular pain and redness with inflammatory deposits. And in this glaucoma flecans, the other options like glaucoma flecan, it represents lens epithelial necrosis. Anterior capsule opacification is usually a postoperative cataract surgery finding. Next question, which of the following statement regarding orbital cellulitis is true? Answer is ethmoidal sinusitis is the most common source of infection in all age groups. So orbital cellulitis is a complication of acute ethmoidal sinusitis. The lamina papacia separating the ethmoid sinus from the orbit is thin and porous, allowing easy spread of infection. Inflammation restricted anteriorly to the orbital septum describes the preseptal cellulitis, not the orbital cellulitis. Management requires systemic intravenous antibiotics, not topical therapy. Orbital cellulitis is typically presents with proptosis, painful restricted eye movements, and pupillary abnormalities, not on normal ocular motility. Next, a 15-year-old girl came with painless swelling, gradually progressed over 1 year. Diagnosis is answer dermoid cyst. So dermoid cyst is a choristoma caused by displacement of the ectodermal tissue along embryonic lines of closure. It presents as a painless, slowly progressive swelling, commonly in the supratemporal or supranasal region of the orbit. It is usually mobile under the skin, often attached to the periosteum with well-defined margins. And lacrimal gland masses, the other options, they typically present in older individuals and may cause infranasal glob displacement. Hemangioma, the vascular lesions often appearing as reddish or bluish swellings. And osteoma, they present as hard bony swelling and is uncommon in periocular soft tissues. Now quickly moving on to the details of this video. A city has 70 lakh urban population and 30% of them live in slums. How many UPHCs are required for slum population according to the NUHM norms? So total urban population is 70 lakhs and some slum population is 30 of 70 lakh, and which equals 21 lakh. As per the National Urban Health Mission norms, 1 UPHC is required for every 50,000 people in slums and vulnerable areas. So dividing 21 lakhs by 50,000 gives 42, which is the required number of UPHCs. Next, which of the following is defined as measuring the degree to which objectives and targets are met and the quality of results obtained? Answer is evaluation. It is defined as measuring the degree to which objects and targets are met and assessing the quality of results obtained as per the World Health Expert Committee on National Health Planning in developing countries. And it assesses the achievement of program objectives, adequacy and efficiency, and measures the productivity of resources and cost effectiveness. Other options like monitoring. Monitoring refers to day-to-day follow-up of activities during implementation and does not assess the final outcome. Planning involves formulation of a plan or blueprint to achieve goals. And supervision, it focuses on the guidance, oversight, and support during implementation rather than outcome assessment. Next, a city experiences a chemical plant leak and toxic fumes are released into the atmosphere. Immediate recommendation to local residents is answer seal cracks and close all the windows and doors. So during a toxic gas leak, the immediate priority is to prevent the entry of fumes indoors. So for that, sealing cracks and closing windows and doors are necessary. It reduces the inhalational exposure and limits the indoor contamination. Next, medical college is organizing a health mela for the community, and a group of students are deputed to a stall to show the Nalgonda technique. And what all materials are required? Chemicals required are alum and lime for that. So Nalgonda technique, it is used for defluoridation of water. Alum acts as a coagulant, helping in flocculation of fluoride complexes, and lime, it increases the pH and facilitates precipitation of fluoride. And other options, the gypsum and charcoal, they are not used in the method for fluoride removal. Next, a 20-year-old man from Chittoor, Andhra Pradesh, presented with weakness in limbs and outward bowing of legs. His diet consisted of jowar, roti and rice. He is diagnosed with osteoporosis. Intervention will you not do? Answer is fluoride supplementation, because Chittoor is a fluorosis endemic area and the clinical features of limb weakness and outward bowing of legs suggest skeletal fluorosis because of the excess fluoride intake. And a diet which is rich in jowar, sorghum, it increases the fluoride retention, predisposing to osteoporosis like bone changes and genu valgum. Management focuses on reducing the fluoride exposure, not increasing it. Hence, fluoride supplementation is inappropriate. Alum and lime, they help in defluoridation of the drinking water. So, changing the water source reduces the fluoride intake, and running surface water usually has lower fluoride content, making them appropriate interventions. Next, a 3-year-old girl presented with difficulty in walking and bowing of legs. She was undernourished and had minimal exposure to sun. Which program deals with nutritional deficiency in children below 6 years of age? Answer is ICDS, that is the Integrated Child Development Services. So, the clinical features such as rickets because of vitamin D deficiency, it is commonly seen in undernourished children with minimal sun exposure. And ICDS, it specifically targets children below 6 years, providing supplementary nutrition, immunization, health checkups, referred services, and nutrition and health education. Others like Anemia Mukt Bharat, they primarily focus on iron deficiency anemia across multiple age groups. And National Nutritional Deficiency Control Program, it is not the primary operational program for comprehensive under-6 nutrition service. And midday meal scheme, it applies to school-going children. Next, new community-based health initiative is designed to reduce the neonatal sepsis. In a community, 20 PHCs follow standard care and 20 are designated to implement the initiative. What type of study design is this? Answer: cluster randomized control trial. So the unit of allocation is the PHC and not individual patients, which defines a cluster design. And entire PHCs are assigned either to intervention or standard care, fulfilling criteria for a randomized control trial at cluster level. Other options like quasi-experimental study, they lack true randomization. Case control studies, they compare exposure between cases and controls retrospectively. And cross-sectional study, they assess exposure and outcome at a single point in time without intervention. Next, as per population strategy, what is the recommended dietary reduction of cholesterol to prevent coronary heart disease? Answer: less than 100 mg per 1000 kilocalorie daily. So under the population strategy for prevention of coronary heart disease, dietary measures, they target the entire population to shift the risk factors at community level. The recommended dietary cholesterol intake is less than 100 mg per 1000 kilocalories per day, and this approach is based on the principle that small reductions in risk factors across the population leads to largest reduction in CHD mortality, that is coronary heart disease mortality, and higher cholesterol limits, they do not achieve the desired population level risk reduction. Next, a 58-year-old male with type 2 diabetes mellitus presents with high-grade fever and cough. He is diagnosed with COVID-19 and is admitted. He dies on 7th day of illness. As part of surveillance, his death is recorded. What type of surveillance is this? Answer: passive. The death because of COVID-19 is recorded through routine reporting from a health facility. There is no active search or direct outreach by health authorities to identify the cases, and such routine notification from hospitals and health institutions characterizes passive surveillance. Active surveillance, it involves proactive case finding by health workers. Sentinel surveillance, it uses selected reporting sites to supplement the routine data, and syndromic surveillance is based on symptom complexes rather than confirmed diagnosis. Next, in a randomized control trial, what is the order of the following steps in a sequential manner from early to late? Answer is randomization, then manipulation, then follow-up, statistical assessment. So, a randomization is performed first to allocate the participants into study and control groups. Manipulation follows, where the intervention or exposure is applied to experimental group. Follow-up is then conducted to observe the outcome, and statistical assessment is then done at the end to analyze the outcomes. Next, a district survey shows that screening of breast cancer increases the 5-year survival rate. However, autopsy showed no real change in mortality. What type of bias is seen? Answer: lead time bias. So, screening detects breast cancer earlier, thereby increasing the apparent survival time without actually delaying the death. Mortality remains unchanged, confirming that the benefit is only in earlier diagnosis, not true prolongation of life. The artificial increase in survival duration is characteristic of lead time bias. Other options like Bergsonian bias, it is related to hospital-based admission differences. Detection bias often occurs when outcome assessment differs due to awareness or exposure, fairness of exposure or intervention. And survival bias, it results from excluding individuals who die early from analysis. Next, which of the vaccines given below would you use for immunization clinic in your hospital? So answer is 1 and 2 can be used, because vaccine vial monitor, they indicate cumulative heat exposure of vaccines, and the vial is usable when the inner square is lighter than the outer circle, and vials 1 and 2, they have a lighter inner square compared to the outer circle, indicating acceptable heat exposure. So vial 3, it has an inner square and outer circle of the same color, indicating discard point has reached. And vial 4, it shows a darker inner square than the outer circle, indicating excessive heat exposure, and the vial should be discarded. Next, in de facto method of census data collection, information is collected based on which of the following? Answer: location at the time of enumeration. So in de facto method, individuals are counted where they are found on the census night, irrespective of their usual residence. So enumeration is based on the location at the time of enumeration, providing a snapshot of the population at a fixed reference point. Usual place of residence applies to the de jure method, not the de facto method. Place of birth and place of employment, they are not the criteria used for census enumeration in this method. Next, few mosquito larvae are seen, and one of them, palmate hair, is seen over the abdomen. It has no siphon tube and is seen lying parallel to the surface of water. What species does it belong to? Answer is Anopheles. So Anopheles larvae lies parallel to the water surface due to the absence of a siphon tube, and presence of palmate hair on the abdominal segments is characteristic feature of Anopheles larva. Aedes culex mansonia larva, they possess a siphon tube and they hang obliquely from the water surface. Next, which statistical test can be used to compare the mean hemoglobin values of two independent groups? Answer is unpaired test. The outcome variable hemoglobin is continuous and the comparison is between two independent. Moving on to the details of this video. First question: a 45-year-old man with abnormal gait and hearing problems presents with a cerebellopontine mass. Histopathological examination demonstrates Antony A and Antony B areas with Verroque bodies. What is the most likely diagnosis? So answer here is schwannoma, cerebellopontine ankle mass with hearing problems and gait disturbance. It is classically associated with vestibular nerve involvement. Presence of Antony A and Antony B areas is characteristic of schwannoma. Antony areas, they show dense cellularity with spindle cells, nuclear palisading and Verroque bodies. And Antony B areas, they are loosely arranged hypocellular with myxoid extracellular matrix. Schwannomas, they are well circumscribed encapsulated tumors arising from Schwann cells and commonly linked to NF2 gene mutations on chromosome 22q12. Glioblastoma, it shows necrosis with pseudo-palisading, malignant nuclei and endothelial proliferation. So other options like oligodendroglioma, it shows round nuclei with perinuclear clearing producing a fried egg appearance. So again, conditions where fried egg appearance is seen, a very important question. And also there is delicate chicken wire capillary network. Medulloblastoma, it is associated with homoviride rosettes. So here is the image showing the Antony A, Antony B and the Verroque bodies which is seen in schwannoma. Next question, a 33-year-old man presents with a testicular bulky mass which was homogeneous, grey white and lobulated on the cut surface. It did not show hemorrhage or necrosis. Microscopic H&E image is shown below. What is the diagnosis? Answer is seminoma. So seminoma occurs most commonly in young adults in the 3rd decade and is the most common germ cell tumor of the testis. Grossly shows a homogeneous grey white lobulated mass without hemorrhage or necrosis, which is typical of seminoma. H&E microscopy, it shows sheets of uniform cells with clear cytoplasm, central nuclei and prominent nucleoli, producing a classic fried egg appearance. And the tumor cells, they have immunohistochemistry which is positive for CD117, OCT34 and placental alkaline phosphatase, that is PLAP. And the other options like embryonal cell carcinoma, it shows variegated appearance with hemorrhage and necrosis. And yolk sac tumor, it shows Schiller dual bodies. Testicular lymphoma, they usually occurs in older patients and it lacks the classical seminoma histological features. Next question, a 28-year-old female presents with multiple cervical lymphadenitis. Immunohistochemical markers, they were positive for CD10 and BCL2. Peripheral smear shows a large number of small cells, that is centrocytes, and occasional large cells, that is centroblasts. Most common genetic defect is T1418 BCL2 IgH. So, clinical picture with painless lymphadenopathy, CD10 positivity and BCL2 expression all are characteristic of follicular lymphoma, and peripheral smear showing predominance of centrocytes with occasional centroblasts supports the germinal center derived lymphoma. So, most common genetic abnormality is T1418 causing translocation of the BCL2 gene on chromosome 18 to immunoglobulin heavy chain locus on chromosome 14. And it leads to BCL2 overexpression and anti-apoptotic protein resulting in prolonged B cell survival. Other options like T25 ALK is associated with anaplastic large cell lymphoma, T1118 MALT1 is seen in MALT lymphoma, and T1114 cyclin D1 IgH is characteristic of mantle cell lymphoma. Next question, in a patient, ileal resection led to fatigue with hemoglobin of 8, MCV of 110 and peripheral smear showed macrocytic anemia. Vitamin deficiency associated is vitamin B12 because ileum is the primary site for vitamin B12 absorption. So, ileal resection, it will predispose to vitamin B12 deficiency. Next question, a young lady presents with jaundice and pruritus. She is antimicrobial, antimitochondrial antibody positive and ANA negative. Biopsy shows portal inflammation and ductular proliferation with lymphocytic infiltrate. What is the diagnosis? Answer, primary biliary cholangitis. So, combination of jaundice and pruritus indicates a cholestatic liver disease. Antimitochondrial antibody positivity, it is a hallmark of primary biliary cholangitis. Liver biopsy showing portal inflammation, ductular proliferation and lymphocyte infiltrate reflects immune-mediated destruction of small intrahepatic bile ducts. Disease commonly affects the woman with fatigue and pruritus as early symptoms, and lab pattern typically shows elevated ALP and GGT rather than transaminase predominance. A choledochal cyst, the other option, it causes obstructive jaundice because of congenital bile duct dilation and lacks autoimmune markers. Autoimmune hepatitis, it is usually ANA positive, and nodular hypoplasia, it presents as a benign regenerative nodule without cholestatic features or autoimmune antibodies. Next, a child presents with visual disturbances and delayed growth. Imaging reveals a suprasellar mass and histopathology shows the presence of wet keratin. Diagnosis is craniopharyngioma. So, in most of the case, whenever the question mentions about a suprasellar mass, it's usually craniopharyngioma. Suprasellar mass in a child with visual disturbances such as compression of the optic chiasma. Delayed growth indicates involvement of the hypothalamic pituitary axis. Presence of wet keratin on histopathology is a classical feature of adamantinomatous craniopharyngioma. Tumor arises from remnants of the Rathke's pouch and it commonly affects children. And the lesions are often mixed solid cystic with cysts containing cholesterol-rich fluid, and it shows calcification on imaging. Other options like glioma, it lacks wet keratin. Medulloblastoma is a posterior fossa tumor and it does not present as a suprasellar mass. Pituitary adenoma, it is rare in children and does not show wet keratin histologically. Next question, an old man complains of fatigue. On examination, there is generalized lymphadenopathy. Which of the following is the investigation that differentiates cancer based on CD markers? Answer is flow cytometry. So flow cytometry differentiates hematological malignancies by detecting the cell surface and intracellular CD markers using fluorescently labeled monoclonal antibodies. It allows rapid immunophenotyping of cells, identifying the lineage and clonality in lymphomas and leukemias. The cells, they are analyzed individually and the results are displayed as dot plots or histograms based on the antigen expression. And gene typing, that it evaluates the DNA sequence and mutations and not the surface marker expression. In case of bone marrow biopsy, it assesses the bone marrow architecture and infiltration, but it does not specifically classify cells by CD markers. And cytogenetics, it identifies chromosomal abnormalities and translocations rather than immunophenotypic CD profiles. So guys, as explained here, you need to know how to rule out the other options as well. So next, a patient presents with cough, stridor and dyspnea. On examination, there was lymphadenopathy. Histopathological examination of the lymph node shows granulomas with giant cells and stellate concretions. Which of the following is the most likely diagnosis? Answer, sarcoidosis. Systemic symptoms with cough, dyspnea and lymphadenopathy suggest the multisystem granulomatous disorder. Lymph node histology showing known caseating granulomas composed of epithelioid macrophages and giant cells is typical of sarcoidosis. Presence of stellate concretions, that is asteroid bodies within giant cells, support sarcoidosis. Granulomas, they are typically naked with minimal surrounding lymphocytes and no central necrosis. Pathogenesis involves increased CD4 plus T cells with an elevated CD4-CD8 ratio and cytokines such as interleukin-2 and interferon gamma driving granuloma formation. Other options like hypersensitivity pneumonitis, it shows poorly formed granulomas with prominent interstitial inflammation. In case of Church-Strauss syndrome, it is associated with asthma, eosinophilia and vasculitis. And there is no granulomas with asteroid bodies in Church-Strauss. And in case of TB, there is caseating granulomas with central necrosis. Next question, caspases are involved in which of the following types of programmed cell death? Answer is pyroptosis and apoptosis. So apoptosis, it is a caspase dependent programmed cell death involving both intrinsic, that is the mitochondrial, and the extrinsic, that is the death receptor pathways. So initial caspases, that is 8, 9 and 10, activate the executioner caspases, that is 3, 6 and 7, leading to DNA fragmentation and apoptotic body formation. Pyroptosis, it is a pro-inflammatory programmed cell death. It is mediated by inflammasome activation and caspase 1 with contributions from caspase 4 and 5. Pyroptosis results in release of inflammatory cytokines such as interleukin-1 beta, and necroptosis, it is caspase independent and mediated by RAP kinases. Ferroptosis, it is iron dependent lipid peroxidation mediated cell death and does not involve caspases. Necrosis, it is an uncontrolled non-programmed process without caspase involvement. Next question, a child presented with fatigue, jaundice and splenomegaly. His father also had similar history. On peripheral smear, MCHC was found to be elevated. Which of the following is the most likely diagnosis? Answer is hereditary spherocytosis. So family history with similar illness suggests an inherited hemolytic anemia, most commonly autosomal dominant. And an elevated MCHC is a characteristic lab finding in hereditary spherocytosis and is uncommon in most other anemias. Clinical features of fatigue, jaundice and splenomegaly results from chronic extravascular hemolysis. And defects in red cell membrane proteins such as spectrin and anchor causes loss of membrane surface area producing spherocytes that are prone to splenic destruction. Peripheral smear, here in the question there was a small mistake. MCHC was found to be elevated and in peripheral smear there was spherical red cells lacking central pallor, which was to be mentioned. And the other options like thalassemia, it is associated with microcytosis and target cells and there won't be an increased MCHC. Sickle cell disease, it shows sickled erythrocytes and vaso-occlusive manifestations. In case of autoimmune hemolytic anemia, it may show spherocytes but lacks a congenital family history and typically has a positive Coombs test. Next question, a 60-year-old man presents with weakness, fatigue and bleeding tendencies. His peripheral smear showed 25% blast-like cells as shown in the image. What is the most common type of genetic abnormality seen in the hematological malignancy? Answer T1517. So peripheral smear showing blast-like cells with multiple ore rods, that is the faggot cells, is characteristic of acute promyelocytic leukemia, that is the APML and APML M3. So APML, it is the most commonly associated with T1517 translocation producing the PML RARA fusion gene which blocks the myeloid differentiation. And clinical features of anemia, thrombocytopenia and neutropenia, they explain fatigue, bleeding tendency and susceptibility to infections. Malignant promyelocytes, they release procoagulant and fibrinolytic substances predisposing to DIC, and inversion of 16 is seen in AML with abnormal eosinophils. T821 is associated with AML with maturation, and NPM1 mutations are common in AML but are not classically associated with Faggot cells or APL. Next, a 6-month-old infant presents with recurrent infections and failure to thrive. Lab investigations reveal decreased B cells, T cells, and deficiency of ADA, that is adenosine deaminase. Which of the following immunodeficiency disorders is most likely associated? Answer is severe combined immunodeficiency. So, recurrent infections and failure to thrive in early infancy indicates a severe primary immunodeficiency. Deficiency of ADA, that is adenosine deaminase, leads to accumulation of toxic metabolites that damage lymphocytes, especially the T cells, with secondary impairment of B cell function. Result is a combined effect of cell-mediated and humoral immunity, characteristic of severe combined immunodeficiency. Affected infants, they commonly present with oral thrush, chronic diarrhea, extensive diaper rash, and severe infections by opportunistic organisms. Other options like hypogammaglobulinemia, it primarily affects the B cells with normal T cell function. In case of DJOT syndrome, it is associated with thymic aplasia, hypocalcemia, and cardiac defects rather than ADA deficiency. And in case of alpha antitrypsin deficiency, it causes liver and lung disease and not immunodeficiency. Next, a 45-year-old man with midline neck swelling presented with odynophagia and dyspnea. The swelling showed cells with variations in size and morphology. Amyloid deposit was also seen, and the swelling was positive for immunohistochemical markers like TTF1, synaptophysin, and chromogranin. Diagnosis is medullary carcinoma. So, amyloid deposition within the tumor stroma is a key diagnostic clue derived from altered calcitonin molecules. Positivity for neuroendocrine tumors such as synaptophysin and chromogranin supports the origin from parafollicular C cells. And TTF1 positivity, it confirms the thyroid origin. And tumor cells, they typically show pleomorphism with polygonal to spindle-shaped morphology arranged in nests or trabeculae. Papillary carcinoma, that is one of the other option. It shows papillae with orphan Annie eye nuclei and samoma bodies. Again, samoma bodies conditions where it is seen. And orphan Annie eye nuclei also image, please note down. It's again very important. Follicular carcinoma, it is characterized by follicle formation with colloids and lacks neuroendocrine marker expression. In case of anaplastic carcinoma, that is an undifferentiated carcinoma, it shows marked pleomorphism and necrosis but does not show any amyloid deposition or neuroendocrine differentiation. Next, a young patient presented with paroxysmal nocturnal dyspnea and hemoptysis. However, the patient succumbed to her illness. On autopsy, the lung showed hemosiderin-laden macrophages. In which of the following condition can it occur except? So, answer is protein-losing enteropathy. Hemosiderin-laden macrophages, that is, which is known as heart failure cells, they indicate chronic passive pulmonary congestion due to long-standing elevation of the pulmonary venous pressure. In case of pulmonary congestion, the red blood cells, they leak from the engorged alveolar capillaries into the alveoli and they phagocytosed by the macrophages, and the hemoglobin breakdown leads to hemosiderin accumulation. In case of other options like right heart failure, it causes it follows the left-sided heart failure. It commonly follows the heart failure causing pulmonary venous hypertension and pulmonary edema with heart failure cells. In case of pulmonary venous obstruction, it leads to back pressure in pulmonary circulation resulting in alveolar hemorrhage and hemosiderin-laden macrophages. In case of volume overload, it increases the hydrostatic pressure in pulmonary capillaries producing pulmonary edema and heart failure cells. And in case of protein-losing enteropathy, it causes hypoalbuminemia and reduced oncotic pressure leading to edema and effusions, but pulmonary congestion with heart failure cells is uncommon, making it the exception and the answer here. Next, which of the following diseases is shown by the pedigree chart? So here it is a case of Kearns-Sayre syndrome, because what is shown here is about the mitochondrial inheritance in this pedigree, and the pedigree demonstrates mitochondrial inheritance where the disease is transmitted exclusively from an affected mother to all of her children irrespective of the sex. Affected fathers, they do not transmit the disease to their offspring, which is a hallmark of mitochondrial disorders. So Kearns-Sayre syndrome is a classical example of mitochondrial DNA deletion disorder. It commonly presents before 20 years of age with progressive external ophthalmoplegia, pigmentary retinopathy, and cardiac conduction defects. Now, forensic medicine. First question, a 35-year-old assaults his co-worker in the office. He was of the opinion that his co-worker was going to kill him as he heard voices in his ear. The patient appears disabled with disorganized speech and What is the best cause of legal action? So here the answer is refer the patient for comprehensive psychiatric evaluation. The presence of auditory hallucinations, persecuted delusions, disorganized speech, and poor self-care, they all suggest unsoundness of mind at the time of the act. So under Bharatiya Nyaya Sanhita, that is BNS, section 368(2), when an accused appears to be of unsound mind during the trial, the court must refer the person for psychiatric or clinical psychological assessment before proceeding. Immediate routine trial is inappropriate without first establishing the mental fitness, and a declaration of not guilty cannot be made without a formal psychiatric report. The behavior is driven by psychosis, not isolated anger, making anger management unsuitable. Next question, a patient comes to the emergency room with complaints of abdominal pain, diarrhea, sweating and blood in stools initially, which later becomes watery. The patient also complains of throat pain followed by purging and vomiting. Vomitus contains bile and blood, and he also has a garlicky odor. What is the likely diagnosis? Answer is acute arsenic poisoning. Garlicky odor of breath and vomitus is a classic clue for acute arsenic poisoning, the gastroenteric type of poisoning. Early bloody diarrhea progressing to watery stools resembling the rice water stools indicate severe gastrointestinal mucosal injury. Throat pain, purging, bile and blood-stained vomitus occurs because of the corrosive and toxic effects on the GI tract. In case of other poisoning, that is in case of phosphorus poisoning, it mimics the GI symptoms, but it is characterized by luminescent vomitus and stools. And in case of aluminum phosphide, it predominantly causes cardiorespiratory toxicity because of the phosphine gas. And in case of croton and jamalgota seeds, they cause intense GI irritation and purgation, but do not produce any garlicky odor. Next question, what is Zasco phenomenon? So answer is tendon reflex occurring after death. Zasco's phenomenon, it refers to postmortem tendon reaction, classically involving the quadriceps muscle. It is demonstrated by upward movement of the patella due to the muscle contraction when the lower third of quadriceps femoris is stuck. This reflex can be elicited up to 1 to 2 hours after death before complete neuromuscular inactivity sets in. Blood clotting, wound gaping and postmortem blood seepage are independent postmortem or traumatic findings, and they do not involve tendon reflex activity. Next question, during the autopsy of a 35-year-old female, the doctor noted bruises below the right ankle of the mandible with a curved scratch on the right side and 3 group bruises on the left side of the neck below the thyroid cartilage, and additional bruises over the head, shoulder blade, backside of the trunk and left iliac crust. Fractures of the superior horn of the thyroid cartilage is present. What is the likely cause of death? Answer is throttling. Because manual compression of the neck, it produces finger grip bruises, grouped contusions and curved scratch marks because of the fingernail pressure. And fracture of the superior horn of the thyroid cartilage, it is a classical internal finding in throttling because of the forceful hand pressure, and multiple bruises over the head, shoulder blade, trunk, iliac crest, they all indicate a struggle and assault supporting homicidal manual strangulation. An absence of a ligature mark excludes the ligature strangulation and garroting. Mugging, it involves compression using forearm from behind and lacks characteristic finger pad bruise. Next question, according to Protection of Children from Sexual Offences, that is the POCSO Act from 2012, protection against sexual harassment, sexual offences and pornography is provided to answer all children under 18 years. So under this act, it defines a child as any person below 18 years of age irrespective of the gender. The act provides gender neutral protection against sexual harassment, sexual assault and child pornography. Limiting protection to under 16 years or to girls alone is incorrect, as the act explicitly includes both boys and girls up to 18 years. Next, the parents of a 16-year-old girl are allegedly kidnapping and rape charges against a 25-year-old man. The accused says he loves the girl and wants to marry her, and that the sexual activity was consensual. The girl also agrees that it was consensual. Examination confirms recent sexual activity, but there are no injuries. What is the likely legal problem under Indian law? Consent is immaterial since the girl is less than 18 years. So the girl below 18 years, it is legally incapable of giving valid consent. Sexual intercourse with a minor is treated as a statutory rape, even if it is consensual. Absence of injuries does not exclude the offence, as force or resistance is not required when consent is invalid due to age. As per Bharatiya Nyaya Sanhita section 63D, sexual intercourse with or without consent with a girl under 18 years of age constitutes rape. The NEET-PG 2025 PYQs rapid revision of the subject microbiology. Now quickly moving on to the details of this video. A patient presented with brain abscess in the parieto-occipital region. Lab findings shows GPB with filamentous bacteria. On modified serum staining, it showed branchial filamentous bacteria which was acid-fast and grew on paraffin-based culture. Which of the following is the most likely causative organism? Answer is Nocardia. So key lab findings include the gram-positive branching filamentous bacilli that are weakly acid-fast on modified Zeren staining. Paraffin-based culture positivity is characteristic as the organism can use paraffin as a carbon source. Clinical correlation, it causes pulmonary infection with hematogenous spread to the brain, leading to abscesses, especially in immunocompromised patients. So the other options, Cryptococcus, it is a yeast with a capsule and does not form filamentous branching bacteria. Actinomycosis, it is branching but it is not acid fast. And Mycobacterium TB is acid fast but does not show branching filamentous morphology and does not grow on paraffin-based culture. Next, a patient was brought to the emergency room with an acute onset of neck stiffness or rigidity and fever, who later succumbed to illness. And given is the image of the postmortem of the brain, which contained the petechiae. Most probable causative organism is Neisseria meningitidis. So acute meningitis presentation with neck stiffness, fever, and rapid deterioration suggests a fulminant bacterial cause. Petechial hemorrhages on the brain are characteristic of meningococcemia due to enterotoxin-mediated vascular injury and disseminated intravascular coagulation. Organism commonly spreads from nasopharynx to meninges, causing separative meningitis and may progress to Waterhouse-Friderichsen syndrome. Mycobacterial TB, it causes chronic meningitis without petechiae. So these are the other options and how to rule out them. Cryptococcus, it typically causes meningitis in immunocompromised individuals and it does not produce petechial lesions. And actinomyces, it is associated with chronic cervicofacial, thoracic and abdominal infections and not meningitis. Next, a sewage worker presented with symptoms of fever, jaundice and conjunctival hemorrhage. He later succumbed to death. What is the most probable diagnosis? Answer, Wales disease. So occupational exposure to contaminated water in sewage work points towards a zoonotic infection transmitted via animal urine. Fever, jaundice and conjunctival hemorrhage are classic for several severe leptospirosis known as Wales disease. The disease involves hepatorenal dysfunction, vascular damage and may progress rapidly to multi-organ failure. The other options, brucella, it has undulating fever, musculoskeletal pain and chronic systemic symptoms. And dengue hemorrhagic fever, it causes bleeding manifestations and thrombocytopenia. Hepatitis A causes jaundice with prodromal symptoms but not cause conjunctival hemorrhage. Next, a 30-year-old young man presents to clinic with recurrent history of disseminated gonococcal infection. Cultures of urethral discharges and synovial fluid from the knee showed growth of Neisseria gonorrhea. Which of the following immunodeficiencies is seen? Answer, deficiency of components C5, C6, C7 and C8. So C5 to C9 components, they form the membrane attack complex which creates pores in the bacterial cell membrane leading to lysis of the Neisseria species. Lowers of the membrane attack complex function. It results in failure to kill Neisseria, causing recurrent bacteremia, arthritis and disseminated disease. So other options like C1 esterase inhibitor deficiency, it causes hereditary angioedema. Myeloperoxidase deficiency, it is associated with impaired killing of Candida and some bacteria, but not with Neisseria susceptibility. And defective neutrophil chemotaxis, it leads to recurrent pyogenic infections. Next question, which of the following is used for syndromic diagnosis of infected cases like meningitis? Answer, multiplex PCR. So syndromic diagnosis aims to identify multiple possible pathogens simultaneously that can cause single clinical syndromes such as meningitis. So multiplex PCR, it allows amplification of multiple target DNA sequences in a single reaction, making it ideal for rapid detection of various bacterial, viral or fungal causes at once. Others like uniplex PCR, it detects only one organism per reaction. Nested PCR, it improves the specificity by using two primer sets sequentially, but it is designed for single target detection. And RT-PCR, it is used to detect RNA viruses by converting RNA to complementary DNA, and it is not inherently meant for multi-pathogen syndromic testing. Next, an old age home resident's son who is a farmer brought food for all the residents. Most of them presented with abdominal pain and bloody stools soon after. On examination, polymorphonuclear cells and gram-negative rods were noted. On epidemiological investigation, it was found that all the affected residents had drunk the same milk. What is the likely organism? Answer is Campylobacter jejuni. So consumption of contaminated milk with subsequent acute abdominal pain and bloody diarrhea points to inflammatory diarrheal illness. Presence of polymorphonuclear cells in stool supports an invasive bacterial etiology. Gram-negative curved rods are characteristic and the organism commonly associated with raw milk and zoonotic transmission, especially from cattle and poultry. Other options, Staphylococcus aureus, it causes toxin-mediated illness with vomiting and non-bloody diarrhea. And Clostridium perfringens, it produces watery diarrhea and cramps, but it is gram-positive bacillus. And Vibrio parahemolyticus, it is linked to raw or undercooked seafood, particularly shellfish. Next, group A streptococci is one of the most common organisms causing pharyngitis in children. Which component of the organism helps it to adhere to the fibronectin of the host cell? Answer is lipotecoic acid. It mediates the adhesion to pharyngeal epithelial cells by binding to fibronectin, which acts as the host ligand. This adhesion is a key virulence mechanism enabling colonization of the oropharynx and pharyngitis. Next question, a 65-year-old man came with complaints of cough, fever and dyspnea. On examination, he has old cavitary pulmonary lesions and hilar lymphadenopathy. On HPE and culture on SDA, a yeast-like organism 2 to 4 micrometer with narrow-based budding is seen, most likely diseases histoplasmosis. So key microscopic finding is small yeast forms 2 to 4 micrometer with narrow-based budding, often seen with macrophages, which is characteristic. Pulmonary involvement with hilar lymphadenopathy and old cavitary lesions suggests a granulomatous fungal infection acquired by inhalation, and the organism is a dimorphic fungus transmitted via inhalation of microconidia from soil contaminated with bird or bat droppings. Next, other options like candidiasis, it shows budding yeast with pseudohyphae, and blastomycosis shows broad-based budding, and coccidiomycosis, it is characterized by spherules with endospores. Next question, a patient presented with swelling of the lower left limb, and on examination inguinal lymph nodes were palpable and were about 1 to 2 cm in size. On FNAC of the lymph node, following was observed. What is the mechanism of likely mechanism for the presentation? Answer is lymphatic obstruction. So sheath microfilaria with nuclei-free tail trip, it is suggestive of Wuchereria bancrofti. Adult worms, they reside in the lymphatic vessels and lymph nodes, causing mechanical blockage and inflammatory damage. This leads to lymph stasis, vessel dilation, and leakage of the protein-rich lymph into the tissues, producing chronic lymphedema and elephantiasis. Next question, a 40-year-old patient presented with fever, cough and dyspnea. BAL sample showed septate hyphae with dichotomous branching on microscopy. Likely organism is Aspergillus fumigatus. So septate hyphae with acute angle, that is dichotomous branching on microscopy, are classic morphological features. BAL sample sensitivity in a patient with fever, cough and dyspnea supports pulmonary aspergillosis, commonly seen in immunocompromised or critically ill patients. It produces invasive disease, allergic bronchopulmonary aspergillosis or aspergilloma, depending on the host immunity. Next question, an abattoir worker presented with a pustular lesion on the rosum of the hand with induration surrounding it. The organism cultured from the lesion showed McFadden positivity and is a gram-positive bacilli. Likely organism is Bacillus anthracis. So occupational exposure in an abattoir worker strongly suggests a zoonotic infection acquired from animal products. A pustular lesion with surrounding induration evolving into a blackish scar is characteristic of cutaneous anthrax, that is Hyde-Potter's disease. McFadden positivity indicates a capsulated gram-positive bacillus, key diagnostic feature. Next question, a 4-year-old was brought to the OPD by the child's mother with a history of intense perianal itching. Was at night. The mother mentioned that she has found small white thread-like structures in the child's undergarments. The stool was examined and the microscopy is shown in the image. What is the likely diagnosis? Entropies vermicularis. So nocturnal perianal itching with small white thread-like worms in undergarments is classic for pinworm infection. The gravid female migrates at night to the perianal skin to lay eggs, causing pruritus and facilitating autoinfection. Egg morphology is characteristic. That is, there is plano-convex D-shaped eggs often detected by perianal swab rather than routine stool examination. Next question, a patient presented with high-grade fever, headache and nuchal rigidity for the past 1 day. Meningococcal meningitis was confirmed. What is the drug of choice for chemoprophylaxis for the contacts of this patient? Answer is rifampicin. So close contacts of meningococcal meningitis, they require prompt chemoprophylaxis to prevent secondary cases. Rifampicin, it effectively eradicates the nasopharyngeal carriage of Neisseria meningitis, interrupting transmission. And prophylaxis, it should be given as early as possible to all the households and close contacts. Other option like doxycycline, it's not recommended for meningococcal contact prophylaxis, and ethambutol is an anti-TB drug, and amoxicillin, it's not reliable for eradicating meningococcal carriage. So that's it guys, microbiology is done. Now quickly moving on to the pharmacology questions. The given image is that of cardiac action potential. In which phase does amiodarone act? Answer is phase 3. So amiodarone is a class 3 antiarrhythmic drug. It primarily blocks the voltage gated potassium channels which are responsible for repolarization of the cardiac action potential, and the phase 3 it corresponds to the repolarization mediated mainly by the outward potassium currents. By blocking the potassium efflux, amiodarone prolongs action potential duration and refractory period, helping to suppress the arrhythmias such as ventricular tachycardia and ventricular fibrillation. Although amiodarone also has sodium channel blocking, calcium channel blocking and beta adrenergic blocking actions, its dominant electrophysiological effect is on the repolarization phase. Next one, benralizumab was given for the treatment of asthma in a patient. What does this drug act on? Answer, interleukin 5. It's an anti-interleukin 5 receptor monoclonal antibody. It binds to the interleukin 5 receptor on eosinophils, leading to antibody-dependent cell-mediated cytotoxicity and apoptosis of the eosinophils. This results in rapid reduction of the eosinophilic inflammation, which is beneficial in eosinophilic asthma. Next question. A 20-year-old female with heartburn and acid taste in mouth was diagnosed with GERD. Which of the drugs will facilitate the increased Gastric emptying and increased lower esophageal sphincter tone. Answer is metoclopramide. It enhances gastric emptying by promoting coordinated upper gastrointestinal tract contractions. It increases the lower esophageal sphincter tone, reducing the gastroesophageal reflex. It acts mainly as a dopamine receptor antagonist with additional serotonin receptor agonist and serotonin antagonist actions. Sensitization of muscarinic receptors on smooth muscle further improves the motility. Next, an elderly male patient presents with fatigue and pallor. After further examination, he is found to have anemia because of CKD. And what will he likely benefit from? Answer, darbepoetin alpha. So, anemia in chronic kidney disease is primarily because of decreased erythropoietin production by the kidneys. Darbepoetin alpha is an erythropoiesis stimulating agent that corrects anemia secondary to CKD by stimulating red blood cell production. It is longer acting than epoetin, allowing less frequent dosing and improved compliance. Correction of erythropoietin deficiency improves fatigue and pallor seen in CKD-related anemia. Next question. A patient underwent chemotherapy and developed tumor lysis syndrome with elevated uric acid levels. He was treated with pegloticase. What is the mechanism of action of pegloticase? Answer is oxidation of uric acid. So pegloticase is a pegylated uricase, that is urate oxidase. It catalyzes the enzymatic oxidation of uric acid to allantoin, which is an inactive and more water-soluble metabolite. Allantoin is easily excreted by the kidneys, rapidly reducing the serum uric acid level, and humans lack endogenous uricase, making pegloticase useful in tumor lysis syndrome and severe refractory gout. So drugs that precipitate gout are cyclosporin or cancer cells, aspirin, niacin, thiazide, Lasix, that is furosemide, and ethambutol, alcohol, and pyrazinamide. So you can remember is that test can't leave. Next, a 40-year-old female was treated for long term with hydrochlorothiazide for hypertension and developed renal stones. Mechanism of action responsible is decreased citrate secretion. Citrate in urine is a natural inhibitor of calcium stone formation by binding calcium and reducing crystal aggregation. Hydrochlorothiazide, it causes loss of hydrogen ions leading to acidification of urine. Acidic urine results in reduced citrate excretion, predisposing to calcium-containing renal stones. Although thiazides decrease the urinary calcium excretion and are often used to prevent calcium stones, the associated hypocitraturia can still increase stone risk. Oxalate absorption is not affected by hydrochlorothiazide. So guys, now quickly moving on to the questions. In which of the following structures will the following epithelium be seen? Answer is ureter. So here the image shows transitional epithelium, the urothelium, which is characterized by multiple layers with rounded dome-shaped superficial cells, and transitional epithelium, which is specialized for stretching and recoil, which is a key requirement in the urinary tract where urine volume fluctuates. And the ureter is lined by transitional epithelium to allow passage of urine under varying pressure. Gallbladder, it has simple columnar epithelium with microvilli, so you need to know how to rule out the other options as well. And in case of trachea, it is lined by pseudostratified ciliated columnar epithelium with goblet cells. Duodenum, it has simple columnar epithelium with villi and Brunner's glands. Next question. A patient presents with carcinoma near the anal opening. Which of the following lymph nodes are most likely to be involved first? So answer is superficial inguinal lymph nodes. So carcinoma near the anal opening, which lies below the pectinate line, an important embryological and lymphatic watershed of the anal canal. So here it is supplied by superficial inguinal lymph nodes. Regions below the pectinate line, they drain to superficial inguinal lymph nodes, making them the earliest site of metastasis. And regions above the pectinate line, they drain to the internal iliac lymph nodes. And anal canal is about 3.8 cm long and is divided into upper mucosal, middle transitional, and lower cutaneous parts, with lymphatic drainage differing across these zones. External iliac and deep inguinal lymph nodes are not the primary drainage sites for carcinoma at the anal opening. Next question. The following image shows a congenital cardiac defect, abnormal development of which arch artery leads to this defect. So answer is 6th left. So here it is a case of patent ductus arteriosus, that is PDA, which results from failure of the closure of the ductus arteriosus after birth. The left 6th aortic arch gives rise to the ductus arteriosus, which normally closes within 72 hours after birth. Persistence of this structure causes a left to right shunt leading to hyperdynamic precordium, bounding pulses, wide pulse pressure, and a continuous machine-like murmur. 4th right arch forms the proximal right subclavian artery and is unrelated to PDA, and 4th left arch contributes to the arch of aorta, defects of which cause aortic arch abnormalities rather than PDA. And the 6th right arch, it forms the proximal right pulmonary artery. So guys, you need to have an idea about which arch, left and right, what forms. So please go through that. Next, during resection of submandibular gland, the following structure was encountered. Identify the same. So the answer is trigeminal nerve. The structure is marked, which is marked as the lingual nerve, which is a branch of the mandibular division of the trigeminal nerve, and the lingual nerve runs close to the submandibular gland and duct, making it vulnerable during submandibular gland surgery. It carries general sensory fibers from the anterior two-third of the tongue and parasympathetic secretomotor fibers to the submandibular and sublingual glands via chorda tympani. Hypoglossal nerve, it supplies motor innervation to the tongue muscles and lies deeper and more inferior. Marginal mandibular nerve is a branch of the facial nerve supplying muscles of facial expression, and facial artery is a pulsatile vascular structure which is not a nerve, and it follows a distinct osseous course over the mandible. Next, an intern was assisting a delivery and the resident asked the intern to come in on the umbilical cord. What is the normal vasculature of the umbilical cord? Answer is 2 arteries and 1 vein. This is a very simple question, guys. So this question, these kind of questions, please don't make it wrong. If at all it comes as a PYQ next in any of the exams, please don't make it wrong. Next, which of the following nerves does not pass through foramen marked by the arrow? So here the answer is hypoglossal nerve. Structures passing through the place which is marked in green here is the jugular foramen. So structures passing through this are the glossopharyngeal nerve, that is the 9th cranial nerve, vagus nerve 10th one, and the spinal accessory, which is the 11th cranial nerve, along with the venous sinuses. And hypoglossal nerve, it exits the skull via the hypoglossal canal. And this distinction is clinically important in skull-based lesions where selective nerve involvement helps localize the affected foramen. Next, a patient presents with pain on the lateral side of the thigh. Doctor diagnosed him with meralgia parasthetica. Identify the nerve. Answer, lateral femoral cutaneous nerve. So meralgia parasthetica, it is caused by compression of entrapment of lateral femoral cutaneous nerve. This nerve arises from the posterior division of L2 and L3 spinal nerves. It supplies a sensory innervation to anterolateral aspect of the thigh up to the knee without motor function. The nerve is vulnerable as it passes under or through the inguinal ligament near the anterior superior iliac spine, where mechanical compression commonly occurs. Common clinical associations include tight clothing, obesity, pregnancy, prolonged hip extension, and inguinal hernia repair. Next, what is the nerve supply to the following labeled muscle? Answer is nerve to mylohyoid and facial nerve. So the labeled structures are anterior and posterior bellies of the digastric. And anterior belly develops from the first pharyngeal arch and is supplied by nerve to mylohyoid, a branch of inferior alveolar nerve. And posterior belly develops from the second pharyngeal arch and is innervated by the facial nerve. This dual nerve supply reflects the dual embryological origin of digastric muscle. Hypoglossal nerve supplies intrinsic and extrinsic tongue muscles except the palatoglossus. Next question, which of the following is not a functional component of the marked nerve in the given image? Answer is general somatic efferent. So again, these kind of questions are a little tricky, but they are scoring questions, so you can learn about that to be in the toppers group. So marked nerve here is the vagus nerve, the cranial nerve 10, identified in the neck descending within the carotid sheath between the internal carotid artery and internal jugular vein. Vagus nerve does not supply skeletal muscles derived from somites, hence it lacks a general somatic efferent component. It carries general visceral efferent fibers providing parasympathetic innervation to thoracic and abdominal viscera. It carries general visceral afferent fibers conveying sensory input from pharynx, larynx, and viscera. It also carries general somatic afferent fibers from parts of the external aortic canal, and motor supply to muscles of the 4th and 6th pharyngeal arch is via the special visceral efferent fibers and not general somatic efferent. Next, a 19-year-old athlete was training. While doing the hyperextension exercises, he felt a sharp pain in the shoulder. His trainer suspected avulsion of the long head of triceps. From which side was the muscle detached? Answer, infraglenoid tubercle of scapula. The long head of triceps originates from the infraglenoid tubercle of scapula. Sudden forceful hyperextension of the shoulder can cause avulsion at this proximal attachment. The long head crosses both the shoulder and elbow joints, making it vulnerable during overhead or extension-based activities. The supraglenoid tubercle is the origin of the long head of biceps brachii and not the triceps. The deltoid tuberosity is the insertion of deltoid muscle. So next subject, biochemistry. Quickly moving on to the first question. An 18-month-old baby presents with weakness of limbs, a cherry-red spot on the macula, and seizures. Mother has a history of spontaneous abortion at 4 months. Lab investigation showed a deficiency of enzyme hexosaminidase. Which of the following biochemical molecules is accumulated in this baby? Answer, ganglioside GM2. So hexosaminidase deficiency leads to impaired degradation of GM2 ganglioside in neuronal lysosomes. Accumulation of GM2 causes Tay-Sachs disease and Sandoff disease, both lysosomal storage disorders. So clinical cues include that neurodevelopmental delay, seizure, seizures, hypotonia, progressing to spasticity, cherryred spot on the macula, blindness, and macrocephaly. So, galactocerebrocyte accumulation is seen in Krabbe's disease because of the beta-galactosidase deficiency. Sphingomyelin accumulation occurs in Niemann-Pick disease because of sphingomyelinase deficiency, and ganglioside GM1 accumulates in GM1 gangliosidosis due to beta-galactosidase deficiency, presenting with different enzymatic and clinical features. Next, a 10-year-old boy presented to the OPD with subcutaneous xanthoma on his elbow. His father also has a similar lesion and he died prematurely because of MI, and lab investigations showed the following: total cholesterol 480, triglycerides 146, LDL-C 300, and HDL cholesterol 26. Which of the following types of hyperlipoproteinemia does he have? Answer: type 2A. So again, types of lipoproteinemias are very, very important. Hyperlipoproteinemia, very, very important, guys. Please learn about it. So here, marked elevation of the LDL cholesterol with near normal triglycerides is characteristic of familial hypercholesterolemia. Subcutaneous xanthomas and premature MI indicate long-standing severe hypercholesterolemia. Type 2A hyperlipoproteinemia results from LDL receptor deficiency or dysfunction, leading to reduced LDL clearance. And type 1 shows severe hypertriglyceridemia with chylomicron accumulation and does not present with high LDL. Type 2B, it has elevation of both LDL and VLDL with high triglycerides, which is not seen here. And type 3 presents with remnant lipoprotein accumulation and typically causes xanthomas rather than isolated LDL elevation. Next, a baby presents with low phenylalanine levels and apparent tyrosine deficiency was seen, but phenylalanine hydroxylase levels were normal. Deficiency of which of the coenzymes can lead to this manifestation? Answer: biopterin. So, phenylalanine hydroxylase requires tetrahydrobiopterin as an essential coenzyme to convert the phenylalanine to tyrosine. And normal phenylalanine hydroxylase levels with impaired conversion indicates a coenzyme, that is tetrahydrobiopterin deficiency, not an enzyme defect. So, BH4 deficiency leads to impaired synthesis of tyrosine, dopamine, serotonin, and norepinephrine. SAM, so S-adenosine methionine, functions mainly in the methyl transfer reactions and is not involved in phenylalanine metabolism. Next, tetrahydrofolic acid, it participates in 1-carbon transfer reactions, especially serine glycine interconversion. And pyridoxal phosphate, that is vitamin B6, it acts as a coenzyme for transamination and decarboxylation reactions, not for phenylalanine hydroxylation. Next, a 65-year-old male with fractured arm presents with bleeding from his gums and perifollicular hemorrhages. His diet mainly consists of tea, biscuits, buns, and bread. Since he stays alone, which of the following enzyme is deficient in this man? Answer: prolyl hydroxylase. So, clinical features of bleeding gum, perifollicular hemorrhages, poor wound healing, and bone fragility points towards vitamin C deficiency, that is scurvy. Proline is incorporated into collagen and then hydroxylated to hydroxyproline by prolyl hydroxylase, which requires vitamin C, oxygen, iron, and alpha-ketoglutarate. Defective hydroxylation leads to unstable collagen, resulting in weak capillaries, gingival bleeding, and bone abnormalities. In bone, failure of osteoblasts to form proper intercellular substance causes weak osteoid, leading to fractures and hemorrhage into joint cavities. ALA synthase depends on vitamin B6. Glutathione reductase requires vitamin B2, and galactosyl transferase does not require any specific vitamin, so they do not explain the presentation. Next, if a frameshift mutation is introduced into a coding gene at the 4th nucleotide of a 900 nucleotide mRNA, what will be the most likely outcome? Answer is complete loss of protein function. So, a frameshift mutation results from addition or deletion of 1 or 2 nucleotides, which alters the reading frame of the codons during translation. From the point of mutation onward, all downstream codons are changed, producing a completely different amino acid sequence. This often leads to a premature stop codon generating a truncated non-functional protein. A mutation occurring as early as the 4th nucleotide severely disrupts the entire protein structure, making complete loss of function the most likely outcome. Next, a patient presents with anemia, ataxia, and neuropathy and a positive Romberg sign. Lab investigations reveal elevated total homocysteine and methyl malonic acid levels, production of which of the following amino acids could be affected? Answer: methionine. So, the combination of megaloblastic anemia, ataxia, neuropathy, and positive Romberg sign with elevated homocysteine and methyl malonic acid is characteristic of vitamin B12 deficiency. So, methionine synthase, vitamin B12 dependent enzyme, it catalyzes the conversion of homocysteine to methionine. Deficiency of B12 leads to impaired methionine synthesis and accumulation of homocysteine. Methyl malonyl CoA mutase, another vitamin B12 dependent enzyme, it converts methyl malonyl CoA to succinyl CoA. Its failure explains the elevated methyl malonic acid. The other amino acids listed, they are not directly dependent on vitamin B12 dependent pathways for their synthesis. Next, a man is stuck in a tunnel for 5 days. He is still alive after 5 days without any food. Which metabolic process is the primary source of energy to his brain? Answer: ketosis. So, after prolonged starvation, that is more than 3 days, the body undergoes metabolic adaptation to preserve the glucose for tissues that are absolutely dependent on it. Fatty acids, they cannot cross the blood-brain barrier, so the brain cannot directly use them for energy. Increased lipolysis in adipose tissue releases fatty acids which undergo beta oxidation in the liver to produce acetyl-CoA. Excess acetyl-CoA is converted into ketone bodies which crosses the blood-brain barrier and becomes the primary fuel for the brain from around the third day of starvation. Glycogenolysis is exhausted within about 18 to 24 hours, and gluconeogenesis alone cannot meet the brain's energy demand during prolonged fasting. Next, a 2-year-old child presents to OPD with delayed developmental milestones, organomegaly, corneal clouding, weakness. Enzyme assay reveals alpha-L-iridonidase deficiency. Which of the following compounds will accumulate in this disorder? Answer: dermatan sulfate plus heparan sulfate. Alpha-L-iridonidase deficiency indicates Herner's syndrome, mucopolysaccharidosis type 1. This lysosomal enzyme is required for the degradation of glycosaminoglycans, specifically the dermatan sulfate and the heparan sulfate. So enzyme deficiency leads to progressive accumulation of these substrates within lysosomes, causing organomegaly, coarse facial features, corneal clouding, developmental delay, and skeletal abnormalities. Next question. A 10-year-old child presents with enlarged orange-colored tonsil. There's a history of death of a family member due to cardiovascular disease. Lab investigations show total cholesterol of 80, triglycerides of 300, HDL of less than 5. Which of the following is the most likely diagnosis? Answer: Tansius disease. So enlarged orange-colored tonsil, that itself points towards this answer, with extremely low HDL levels are classic for Tansius. The disorder is caused by deficiency of ATP binding acid transporter A1, ABCA1, leading to impaired cholesterol efflux from peripheral tissues to HDL. As a result, HDL and LDL levels are markedly reduced while triglycerides are elevated. Cholesterol esters, they accumulate in tissues producing orange-yellow tonsils, hepatosplenomegaly, peripheral neuropathy, and premature cardiovascular disease. Next, the A-beta lipoproteinemia, it causes fat metabolism in acanthocytes. Niemann-Pick's, it leads to sphingomyelin accumulation, and familial hypertriglyceridemia, it shows markedly elevated LDL rather than very low HDL. Next question. A 10-year-old girl presents with freckles on face, neck, arms, and hands. These lesions are sensitive to sunlight. She also has 2 basal cell carcinomas on her face. Which of the following defect is seen in this girl? Answer: nucleotide excision repair. So again, these defects are very, very important, guys. So the presentation of photosensitivity, freckling on sun-exposed areas, and early onset basal cell carcinoma, they all point towards xeroderma pigmentosa, and this condition results from a defect in the nucleotide excision repair, the pathway which is responsible for removing UV-induced thymine dimers from DNA. So failure to repair these lesions leads to accumulation of DNA damage, causing mutations and a markedly increased rise of skin cancers in childhood. So base excision repair handles small base modifications. Mismatch repair, it corrects the replication errors, and non-homologous end joining repair repairs the double-stranded breaks, none of which explains the extreme UV sensitivity with early skin malignancy. Next question. A man on long-term hydrochlorothiazide presents with cerebellar ataxia, horizontal nystagmus, bilateral symmetrical sensory and motor peripheral neuropathy, and right heart failure. No history of alcoholism is present. Which of the deficiencies associated with this? Answer: thiamine. So combination of cerebellar ataxia, horizontal nystagmus, and ophthalmologic signs such as Wernicke's encephalopathy, while bilateral symmetrical peripheral neuropathy and right heart failure indicates beriberi. Both neurological and cardiovascular findings point towards vitamin B1 deficiency. Long-term diuretic therapy such as hydrochlorothiazide increases the urinary loss of thiamine, predisposing to deficiency even in the absence of alcoholism. Thiamine deficiency, it impairs the enzymes involved in carbohydrate metabolism, leading to reduced ATP production and dysfunction of nervous tissue and myocardium. Selenium deficiency, it causes cardiomyopathy without neuropathy. Zinc deficiency presents with skin and wound healing issues, and vitamin B12 deficiency leads to subacute combined degeneration without heart failure. Now moving on to the physiology questions. In an experimental study of insulin after glucose administration, blood glucose was brought to 300 mg per deciliter and maintained at that level. What will happen to insulin in this condition? So answer is insulin increased initially and maintained at that level. So insulin release after glucose administration is biphasic. An initial rapid rise occurs due to the release of the preformed insulin from pancreatic beta cells. With persistent hyperglycemia, insulin level rise again due to newly synthesized insulin, and this second phase is slower, sustained and prolonged, leading to maintenance of insulin at a plateau. A steady continuous rise does not occur because insulin secretion reaches a regulated plateau. An initial rise followed by decline occurs if hypoglycemia is transient, not when glucose levels are maintained. Next question. The point B in the length tension graph of sarcomere depicts which of the following illustrations? So here the answer is third one. So point B represents the sarcomere length at which full muscle tension is maintained. At this point, actin filaments are just beginning to overlap each other while still having optimal overlap with myosin heads. This configuration allows maximum effective cross-bridge formation without interference between actin filaments. Excessive shortening causes actin-actin overlap and reduced force. Next question. A young man travels from Delhi to Leh, which is at 3,700 meter above the sea level, and started to experience dizziness, nausea, discomfort, and headache. Which mechanism is responsible for the symptoms? So again, this kind of questions, yes guys, you need to have an idea. So decreased PO2 causing cerebral vasodilation leading to fluid leakage from the intravascular space. So rapid ascent to high altitude leads to reduced atmospheric oxygen pressure and decreased arterial PO2. Hypoxia causes cerebral vasodilation, increasing the cerebral blood flow and capillary hydrostatic pressure. This promotes the fluid leakage into brain tissue, producing symptoms like headache, nausea, dizziness, and discomfort. This mechanism underlies acute mountain sickness and can progress to high altitude cerebral edema. Respiratory alkalosis occurs due to hyperventilation, not increased by bicarbonate or hydrogen ions. And hypoxia causes cerebral vasodilation, not vasoconstriction. Next, if there is zero filtration across the capillaries, then what is the interstitial hydrostatic pressure? Given that capillary hydrostatic pressure is 18, capillary oncotic pressure is 27, interstitial oncotic pressure is 7. So here the answer is -2. So you need to know how is the Starling's equation. Net force is equal to capillary hydrostatic pressure minus interstitial hydrostatic pressure. The answer of that minus the capillary oncotic pressure minus interstitial oncotic pressure. So substituting the values, we will get the answer as -2, indicating a slightly negative interstitial pressure that balances forces and prevents net fluid movement. Next, the given graph shows PCO2 and PO2 of the right lung along with the ventilation and perfusion ratio. Which point on the graph represents the V/Q ratio if there is a complete block of the blood supply at the alveolar level of the right lung due to pulmonary embolism? So pulmonary embolism, it causes complete absence of perfusion to the affected alveoli while ventilation is preserved. This results in V/Q becoming infinite. So guys, you need to know when the V/Q will be infinite and all those conditions and values. So as ventilation is present but blood flow is 0. Gas composition in such alveoli approaches inspired air with very high PO2 and very low PCO2. On the graph, this physiological state corresponds to extreme right point indicating maximal PO2 and minimal PCO2. A V/Q ratio of 0, when is it seen? It occurs when ventilation is blocked, not when perfusion is blocked. So lower or highest regional V/Q ratios within the lung do not represent complete absence of perfusion. So that's it guys, we have completed all the subjects NEET-PG PYQs. So guys, yeah, the PDF is available as I've mentioned previously. You can check out my Telegram channel or my super profile in order to have an access to the PDFs, and we'll be soon coming up with INICET and FMG PYQs as well. So till I come back with my new video, stay tuned. Till then, bye.